Oh, good. All right. Good morning, everybody. You're very welcome to the board meeting for Kettering General Hospital for July. We have apologies from Simon Weldon, Andy Callow, Richard Apps, Edmund Burke, and Chris Welsh. Do we have any other apologies, Richard, wherever you are?
No, just those, Alan. Thank you.
Thank you. And do we have any declarations of interest? Nope. Okay, you're all very welcome. We're going straight into the staff story where we have a live presentation and actually face somebody live as opposed to a video. But Faye will introduce the whole thing. It's part of a theme about theatres and theatre productivity today. Faye, over to you.
Chair. Yeah, so as you say, with the very much focus on reducing waiting times, we thought it pertinent to share with you some stories around theatres. So firstly, we'll show you a video from Rosa, who's our very energetic theatre practitioner, and she'll tell you about what it's like to work in theatres. We've got a short video on sterile services, because there's lots of elements of preparation before a patient gets to a theatre. So there's a short video to show you around that. And then lastly, we'll hand over to Rob Haywood, who will just give a very brief summary of some of the work that's currently underway within theatres to see how we can improve and whether we can be more efficient, so to enable us to treat more patients. So without further ado, I'll hand over to Rosa. And we'll hear her video. Thank you, Chair.
Hello, my name is Rosa. I work as lead theatre practitioner. Working in theatres is very exciting, as most of the time we don't know what's coming through the doors, but we're always ready to deliver safe, compassionate and excellent patient care by being outstanding employers. Different is for our elective list, where we try and plan things 6 weeks before, making sure that we have the right staff, the right skill mix. Obviously, we make sure the surgeon and anaesthetist are aware of the list and what they're doing before they see the patient, and obviously we make sure that piece of equipment that surgeon might require on that day is on place, or if we need to order a specific piece of equipment, we'll do that, or maybe order as well a kit from another hospital. Obviously, there are lots of checks that we do on the same day of the operation. We not only do some health and safety checks, such as checking the diathermy machine, the suction, checking anesthetic machine, control drugs, but we even perform some infection control risk assessment. On the same day of the operation, we even obviously go through another with the anesthetic team and surgical team to make sure that obviously we discuss about the patient on the day, and we make sure that obviously we know about any extra concern for the patient, what kind of airway tube they need. Obviously we discuss if there is an unexpected risk for the patient, if patient is allergic to anything, if there is a side that we're going to perform, which side we are doing, if patient is being group and screened that day if needed, so, or for example obviously if patient needs a catheter, or obviously if there is any unexpected stuff that over the surgery can happen. Before we take patient to theatres, there's another check that our operating department practitioner would do. We'll go around the ward, or for example in our reception in main theatres, and check obviously that we have the consent form and patient agrees with whatever we're doing in theatres. And obviously if there is a side that we are doing, we check that that side is actually being marked to make sure that we do the correct side at the same patient, at the correct patient. Obviously the last few years have not been easy for our department, as we had to go through the pandemic, and obviously we had to decrease our theatre activity, and most of our staff had to be redeployed to intensive care unit or the department. They, I would say, have managed very well, and obviously they have learned all the skills, and they've been helping and supporting not only the staff in all the departments, department, but obviously they have been supporting the critical care patients. Obviously, working in theatres can be quite tiring, as most of our team sometimes works through breaks, sometimes not even having breaks. But obviously we wake up every day making sure that we deliver and we ensure high standard of care to our patient, and we always try and work within our trust value, being compassionate, caring to our patient, accountable for anything we do, respecting each other, engaging with the team, and obviously trying and always be honest and trustworthy. What I love about my job is obviously not only caring for the patient, but sharing this experience with my colleagues and teaching and training the new staff and the students to make always sure that we do an excellent care to our patient. And obviously what everybody loves about it is being a teamwork, because this is the key of obviously having and being an excellent team. Thank you.
Have we got the next video, Faye?
We have indeed. Just 1 second.
Thank you.
Thank you, Richard. So just before we go on to talk to Rob, I think what we wanted to try and do today was just demonstrate how complex running a theatre can be. And you can see so many people are involved in just the element of equipment and getting that ready for when a patient comes into surgery. And I think Rosa also articulated some of the checks and balances that have to happen. So from day one, once the surgeon has agreed to take the patient to theatre, there's so many things that we have to ensure are lined up before the patient is received into theatre. So I hope that sort of gave you some insight into some of the things that have to happen in readiness for a patient to come to theatre. So it's okay, we'll just sum up with Rob Hayward, who's our Divisional Director for Surgery, and a new Divisional Director to Surgery, who will just briefly talk to you about some of the transformational work that the team are doing and supported by Rob in terms of how we make sure we're absolutely maximising all of our theatre capacity, because it's a great asset to the organisation and we need to ensure that we are treating as many patients as we possibly can. So if it's okay, I'll hand over to Rob. Thank you.
Thanks, Vane. Thanks, everybody, for allowing me to come along today. I really am grateful to represent the theatre team and the elective team today. So the work we're doing actually is about far more than transforming theatres and the way that our operating theatres work. It's about ensuring that the experience that our patients get from the day that they're told that they need an operation improves. So it starts with pre-assessment, and it's about ensuring that our pre-assessment services meet the needs of our patients, only assessing patients that need to be assessed, because we assess patients that don't need to be assessed at the moment, and making sure that those that need a full assessment by a consultant anaesthetist at the far end of that spectrum also get that service when they need it, far enough in advance to be able to do something about any underlying health conditions so that they can be treated through our operating theatres. It's about creating a pool of patients so that are ready to be booked, that are fit for surgery, so that we cancel less patients on the day of their surgery for reasons that are unavoidable, because unfortunately we do that most days. This work is about improving the booking of patients so that they can get a minimum of 3 weeks notice of their operation date. We give too many people too unreasonable a time frame in order to make arrange their personal lives to be able to be operated on, so that they can be confident that list is going to go ahead, because we've got a surgeon, we've got an anaesthetist, and we've got theatre staff booked. And that sounds really obvious and really easy, but the coordination of theatre staff, patient, surgeon, and anaesthetist is a lot more complicated than I ever imagined it could be. Our staffing within theatres anaesthetics at the moment is too fragile, and so we do lose patients. We do lose lists, operating lists, with patients that are booked on them every week. And because this work is about ensuring that we're able to make best use of our theatre complex, it means that if we can get to 95 sessions a week through improved staffing and more robust staffing, we can treat an additional 135 patients a month through our theatres. So we're aiming for 95 sessions a week, and last week we managed 80. It's about ensuring that the experience that a patient gets on the day of their surgery is better. The first patient in the anaesthetic room for 8:30 in a morning list, so that we can be more confident that that morning list can be completed in time for the afternoon list to start on time. It means, again, less patients are cancelled. So we have a huddle every afternoon between the theatres and the wards, so that we get that golden patient down to theatres efficiently by 8:30 in the anaesthetic room. Every morning at 8 o'clock, we have another huddle to go over the day's plan and make sure our elective and our emergency theatres, which are critical to the running of the entire hospital, work well, are safely staffed, and our patients can be treated, transferred back to the ward, and then discharged safely to recover at home. The there's a lot to do. There's a lot to do. Our team is tired, as Rosa explained, after a pretty difficult couple of years, particularly for our theatre staff who were spread very thinly and moved quite a lot into the intensive care unit. But those staff are committed to improving the way in which our theatres work for our patients. And they take great pride in their work, and so they should. They are incredibly highly skilled people. And with people like Rosa at the helm, we will be able to work tirelessly to increase the number of patients that we can get through our theatres every week and that are safely treated so that they can have a good patient experience and be from the point that they're added to the waiting list to the very point that they're discharged from home.
Thank you, Rob. Thank you, Chair.
Okay, that was an interesting run through about how theatres work. Any questions or comments to Rob now, or comments on what you saw before? Debbie?
Yeah, thank you, Chair, and thank you, Faye, and especially Rob as well for joining us today. We're going to be discussing activity later on in the agenda today, but we do need to be able to deliver the 95 lists to get to our activity targets. And at the moment we are falling short of that. But I hope that colleagues and the public have just been able to see this morning the huge amount of work that actually has to take place every single day to get the right patient into the right place at the right time by the right and being operated on by the right person. I'd also just like to thank Rosa, actually. It's not easy doing this sort of thing, and she's clearly doing a very good job at the moment, so thank you. And equally to our sterile services staff. Thanks, Chair.
Thank you. Lisa?
Hi there, thanks. Just to reiterate what Deborah's just said, really good presentations, great to see so much work going on. Rob, just a query. I'm really pleased that the anaesthetists are seeing people ahead so that we can deal with any medical issues. When people are listed, so when the surgeon says you now need an operation, do we give them information about what they can do to get themselves in the best possible place to be fit for their surgery? So we know that actually, even if you give up smoking 3 weeks in advance, you'll have better outcomes, better lower risk of infections, more likely to leave hospital. I just wonder what we're doing in that area to kind of get patients to.
Yeah, that's no, fine. So there are individual conversations that take place between doctor and patient at the time. That is not formalised or managed in any way, of course, because it's an individual conversation. But we do have leaflets that, when patients are added to the waiting list in clinic, that the patient is given some preoperative advice on what will happen next, so that they understand the process. And they will also get a letter that explains that the pre-op assessment team will be in touch with them as well. And so from the 1st of September, we're not going to be doing a pre-op assessment on any local anaesthetic patients because they aren't needed. And that will free up really, really key capacity for us to be able to get further ahead and create that pool that I described. But it does mean that patients will be pre-assessed further in advance than they currently are. It can be less than 2 weeks before their operation at the moment when we have a pre-assessment, and we want to get to the point where it's 4 to 6 weeks at least when they have their pre-assessment, so that counselling and that advice can be made more clear. The vast majority of them will be over the telephone, and that's absolutely fine. It's absolutely safe, but we can still provide any literature that's required or anything in advance as well. And for those that are at greatest risk, it would be a face-to-face appointment in a clinical area, so that we've got all the facilities required to ensure that the patients are as safe as possible for when they come in.
Okay, thanks, Rob.
Okay, any other questions or comments about I see Chris Welsh is here. Have your apologies then, Chris. That's nice to see you. And yeah, as the one person in the room who's been in the theatre more than anybody else, I suspect. Perhaps maybe I might make a claim, but anyway.
I think the only comment I would make is it's a delight to see the quality of the staff and the quality of the service being provided. I know we need to do more lists, but it is really a monumental effort to get all of those particular things together for a single patient's operation. So it's really good to see this, and thank you to the organisation. And thank you, Rob.
No problem.
Okay, thank you. I certainly agree. And Rosa was quite an impressive performer on the video. Okay, Rob, this is your lift conversation. What's the biggest thing stopping you doing 95 lists?
Oh, the biggest thing stopping us doing 95 lists is the availability of theatre staff. We are out to agency at the moment. The agency staff can pick and choose who they want to go to, and it's certainly a buyer's market. We did get some really good news yesterday that we've got 3 additional staff coming in the next couple of weeks. That will make a big difference. That will probably add about 5 lists per week, which is great, but we need to get a total of 7 out. So we've got 3, we need a total of 7 more staff. We have a recruitment in process and in train, so we have got people on the way. But these things take time, and it's really frustrating that these things take time. So we need to be able to ensure that we've got sufficient theatre staff, and then we also mustn't forget the anaesthetists. We're a couple of anaesthetists short to be able to fully staff 95 lists using substantive anaesthetic lists. We currently use waiting list initiative lists, and as a result of that, we lose, because there's only so many volunteers for that kind of thing, we lose about 5 theatres a week because of anaesthetic availability as well. So we've got to make sure that we balance both of those things. Once we get to 95, it's about absolutely ensuring we flood the lists and book them fully. And so separately and alongside, we are absolutely working really, really hard with our booking team to ensure that we are booking well ahead, that they are fully skilled in being able to do that. And as my 14-year-old daughter told me the other day, it's just about communication and getting the anaesthetic team, the theatre team and the booking team to talk to each other in every single day, so that we're all fully informed about where we need to be.
Okay, so you're telling me we've got a plan for the ODPs and nurse recruitment?
Yes, we do. And we present that plan to Faye every week so that we can see where we are in our trajectory towards improving our staffing. Which gets us to 95 lists, which I suspect will be about the middle of September.
And does that include a plan for 2 new anaesthetists then?
So with regard to anaesthetists, there's a meeting taking place today with our finance partners to see about what we currently spend and how we can spend that more creatively and differently to create specialty doctor roles, which allow us to have independent, more junior doctors, but independently working on theatre lists that are safe to do so. And that will be a game changer as well if we can get 2 to 3 of those.
SSDs, yeah. Okay, thank you very much. Anybody else picking anything up from that? No? Okay, Rob, thank you very much for
thank you.
Talking to us today.
Take care. Have a good meeting.
And congratulations to the team. And, you know, I think you're entitled to pick out Rosa for special congratulations as well. But
absolutely.
Thanks to the Sterile Services, the SSD team too.
Take care.
Okay,
bye-bye.
Thank you. Right, everybody, minutes of the previous meeting held on the 27th of May. You're happy to a fair record? And the action log is complete, well, apart from the issue of KPIs for comms, which of course is not complete because we're waiting to get a new group director, and no appointment was made in the last interview. You're aware of some of the reasons for that, perhaps. And I'd also say, I think, I'm not entirely sure everybody fully appreciates the damage, if you like, done by not having a fully functioning group comms directorate for over a year. But anyway, Lisa and then Fiona.
I think we're probably going to speak to the same point on the minutes, which is the maternity minutes are wrong. The target is not 100% of women to have continuity of care by March. It is 75% of women by 2024. So if we could just alter that, please.
Mr. May, you'll correct that, please.
Thank you.
Yes, yeah, indeed.
Same issue, Fiona. Yeah. Yeah. Okay, thank you for correcting that. Where am I now? Oh, yes. Chair's report. Right. Well, first of all, I'm pleased to report that we've appointed Deborah Manger to the position of non-exec director. She'll be starting with us on the 15th of August, having completed all the checks for a 3-year term. Deborah was the outstanding candidate from over 27 applicants, and was unanimous choice of the Council of Governors selection panel. Just as a bit of background, Deborah was at one point in her life, I suppose she still is actually, a dentist. Once a dentist, always a dentist. But she was Deputy Medical Director of NHS, Northamptonshire Northamptonshire Healthcare Foundation Trust, NHFT, thank you, and has also worked with Health Education England and with the regional NHS England organisation, and does a number of other things as well, as you might expect, having retired a little while ago from those roles. So she'll be starting with us there, and amongst other things, we'll be doing the charity trustees, which we come to later on the agenda, Northamptonshire Health Charity, and she'll also be doing the People Committee. We also should congratulate the governors who presented a showcase at the annual NHS Providers Governor Focus Conference, and that's the second year in a row they've done that, and a joint submission again with NHFT, rapidly becoming our best friends, on the programme of joint ICS briefings that we've been running between the governors of both organisations. Just while we're on ICBs, ICS, ICB integrated care boards, might point out that it now exists, having come into existence on the 1st of July, and so far had one meeting, which was mostly devoted to development work, as you might expect at that point, with a programme of development about the people who have to try and work together in a way that perhaps they haven't done before. Quite a lot of new appointments at non-exec director level in the ICB as well, to get their feet under the table. And finally, congratulations to our non-exec director, Edmund Burke, who's not with us today, but he's been appointed as Vice Chancellor of Bangor University, taking up his new post on the 1st of September. And since his appointment is linked to his employment with Leicester University, his replacement will, as the University of Leicester non-exec director, will be nominated by the university, and I'm in conversation with Tom Robinson, the head of school, about that. So straight on, Simon's not here, as you know, so Mark, looking a little bit like Simon, will be doing Simon's report today. So, Mark.
Wow, how to start that, eh? Mark looking a little bit like Simon. Thank you so much, Alan. You're not too far from it yourself. So just in terms of the report, I'm going to take it as read from Debbie's going to discuss urgent care in her report, and she and I have obviously discussed, and we don't wish to duplicate things, so you'll be pleased to hear about that. With regards to activity in theatres, that's also on the agenda, so I wasn't going to cover that in any great detail. There's a couple of bits that I was going to centre some attention upon, though, obviously, which is our dedicated to excellence hour. So this is Genesis born from our board session at the end of April, and whilst we know we have our next board development session on the 3rd of October, one of the things that we really wanted to get on and progress was the dedicated to excellence hour. So we know that this works, and particularly in this organisation, and Lamport and Twirl being an outstanding example of that. Whereas if we can give people some time and some investment, they can make leaps and strides in terms of improving their own work area, and that improvement and that empowerment leads to higher motivation, which hopefully leads to a different culture and people feeling differently about the place in which they work. So we're really looking forward to seeing the fruits of that in the near future, and of course Dragon's Den coming back, if you like, in October following the pandemic. The main thing that I wanted to obviously focus my attention on with regards to Simon's report as he's written it is regards to just thanking our colleagues within and around the organisation. I think these last couple of weeks and months have been really challenging again. We've had an additional COVID wave, which I have no doubt will come up during our conversations, particularly in the IGR, but the impact that has upon colleagues by colleagues being absent and therefore having to cover again is really challenging, and we see that in our absence results. And also we can't have this conversation without recognising the heat wave. So the position that colleagues were under just a week ago, beginning of last week, with those extreme temperatures. We know about our hospital, we know about our building, we know we're trying to improve it, but it currently has severe limitations when it comes to heat and how we can try to keep people cool, particularly those providing care, but also those that support those providing care. I think one of the things that we really recognised during that last week was the additional hours and the work that people put in with regards to estates and facilities, and also within our digital department, particularly the calling of all of those servers, which if they go down would be very, very detrimental and have a huge impact on our ability to deliver the high quality care. So I just wanted to reach out and thank those colleagues, and I will close the report there. Thank you, Chair.
Thank you very much. I mean, those of you who read the press will know that there were hospitals where their digital systems went down completely during the heat wave and had all sorts of detrimental effects. So it takes a lot of people to make this system work well. And I was in on one of the heat wave days in the evening to see what it was like, and it was, I have to say, pretty unpleasant. And of course, as we all learned quite quickly, deeply counterintuitive to live in a heat wave with the windows shut. But the heat was outside, not inside, so it was just a little bit of a problem. And for those areas that didn't have adequate shading, that became really, really difficult. So thank you, Mark. And we certainly, staff went more than the extra mile. They went the extra several miles, I think, on the head of that. But I'm sure Debbie will refer to that as well. Debbie, straight on to you.
Yeah, thank you. Before I start my report, I think there's one element that you did miss off, Mark, from Simon's report, and that's the fact that this is your last board. So on behalf of Simon and certainly the exec team, I'm sure Alan will also mention this, huge thank you to you. You've been a fantastic colleague and a huge amount of support to me personally and professionally. So big thank you, and huge amounts of luck with the new role. So I'll start my report by thanking our staff. It's been a really challenging few months, and the last couple of weeks extremely challenging, and thank you doesn't often seem to be enough when you say those words, but you know, at the moment that's the biggest thing that we can say. Thank you. The heat wave, as Marcus said, had a particular challenge for us as an organisation, especially due to our electrical infrastructure. So we had staff that were unplugging some equipment to be able to plug fans in for a period of time and then rotating back to the equipment. And again, that just gives you a view of the difficulties that we are facing with our estate as it currently is. Particular thank you, as Mark said, also to the digital and estates team. They were on site 24/7 throughout that 2-day particularly difficult period, and did a fantastic job, so thank you. You will be aware that we reintroduced our face masks for both staff and visitors on the 12th of July, having agreed only a month earlier to relax those guidelines. Our decision was taken at the time because of the steep increase in COVID inpatients and also staff sickness due to COVID. I am pleased to inform you that when I wrote my report, you could see the number of COVID patients had increased. That's now decreased down to 39 patients today, which is fantastic. We're starting to see that the decrease drop quite rapidly. In terms of discharge, so we continue to be involved in the National Hospital Discharge Programme. It's going well. We have got our board rounds in place along with 7-day working. And over the last few weekends, we have discharged a lot more patients than we have been doing previously. And colleagues will be aware that generally Mondays and Tuesdays are our difficult days because we don't normally discharge as many patients at the weekend. And then of course that backlogs on to early in the week, Monday, Tuesday. So really good progress in that respect. We have seen an increase in our A&E attendees. They're predominantly minors, but also a slight increase in our admissions over the last months. We've seen an increase in acuity of admissions as well, and often it can be quite easy to say that, but we have seen an increase in number of patients that are on ITU. Again, another marker that acuity is high in the organisation. Changes prior to winter. So I just want to let the board know that we, as a system, will be making changes to Pathway 2. And this is generally rehab patients in the community and in our community hospitals. So across the county, we will be increasing our acute confusion beds in the community, but also managing our specialist care centres and rehab beds differently, with the aim of increasing discharges across both Northampton and Kettering. There will be an increase in beds in the community in this regard. So an increase in both specialist care centre beds to manage rehab patients, and also an increase in acute confusion beds, which is really, really good news. Collaboration across the county to make these changes has been really good. So NHFT will be taking the lead on this plan, but this plan is absolutely not without risk ahead of winter. We will have to recruit over 120 new people, and that's across the board: nurses, I was just about to say midwives then, but that's not the case. Nurses, AHPs, social workers, social care staff, rehab assistants, matrons. So this is recruitment across a broad range of staff. And of course, that does provide a risk when each healthcare provider in the county is currently struggling to recruit the amount of staff. So it may well mean that we see staff leaving KGH, NGH to go and work in specialist care centres. So yeah, the risk is fairly real there. In terms of our staff, they continue to do a good job, but being out and about in the organisation, along with the exec team over the last couple of months, you can see that the challenges of the increase in activity and the demands due to unavailability of our staff are clearly having an impact. What we have done though, we've had some successful targeted recruitment for healthcare assistants in the last month, and we're planning the same for our estates and facilities and allied health professional staff over and after the summer months. Our plans for our staff restaurant, you'll be pleased to know, are progressing well. We are planning for the new facility to be in place by the end of the financial year, and we've got some champions helping us to design the new facility and also work with us on what food we will be providing. So you'll see from my report that we've celebrated many things over the last couple of months. The one that I'd really like to just pull out is the Macmillan Cancer Support Centre. And I spent some time with some of our patients who have had cancer, are in progress of having treatment or have recently recovered from having treatment. And I must say it was really humbling to hear their stories. And for them to be able to come together once a month for just a coffee morning for just a couple of hours, you could really see the impact that that was having on them, being able to discuss with friends now the impact that the treatment and the diagnosis of cancer had had on them and the support. And I was really pleased actually to be able to meet with some of our staff who've pulled the Macmillan Cancer Centre together, the information centre. What I would say to colleagues is if you haven't been able to visit the area yet, you've not had the opportunity, please do try and make the time to go down there. It's a fantastic facility and a real asset for us and our patients. In terms of the next few months, I think one of the main focuses for me and the team is to continue to help our divisions gain a better understanding that the impact that COVID has got on our activity. This is also going to be really useful for discussing with system colleagues the impact that our activity versus plan has. And we'll obviously be discussing activity later on in the agenda today. And finally, our Cardiology Centre of Excellence plans are progressing. We're currently planning our second away day event that will hopefully be taking place in the autumn, date to be confirmed, but invites will be going out fairly soon for that day. What we'll be seeing over the next couple of months is that we'll be putting in place some pooled lists to make sure that we've got access, equitable access for our patients throughout the county. And we'll also be increasing our 7-day services with some new rotas for our staff. So I'll stop there, Chair. A lot to cover there today, but I'll take questions. Thank you.
Okay, thank you. Any questions on any of those three reports? Trevor.
Thank you, Debbie. I think just going back to what you were saying about pathway 2, and it's it's going to be really good getting those extra facilities in, but facilities are one thing, communication is another, and it's how we make sure we can test before the winter sets in, that we've also got the communication between ourselves as acute trusts and those community facilities to make sure that those receiving the patients, they will still be patients, know what and who they are, so that we don't end up with a revolving door of patients coming back into the acute hospitals sort of within 24 hours.
Yeah, thanks, Trevor. That's a really important point that you make. So the community colleagues will be will be part of our discharge hub. The one thing that we are very keen to do with this piece of work is to make sure that we have got trusted assessor in place, so that we're not having multiple assessments of patients before they go out. So communication is absolutely key at this point, to be able to make sure that the patients don't bounce back to us, because that's not what we need. And equally, what we also need to do, and yeah, Becky, I can see Becky wanting to come in at this point because it is part of the ICANN work that Becky is leading. What we also need to do is make sure that patients don't just bounce back to us if they are placed in an area that perhaps is not right for them. So, for example, there might be a patient who is transferred to a specialist care centre. The communication is fantastic, but actually their needs are a little bit greater than what a specialist care centre could give. What we then need to be able to do is rapidly act to put some care around that patient rather than them coming straight back to the acute hospitals.
Becky.
Yeah, I just wanted to come in. I think as well as the additional capacity within Pathway 2, it's also increasing the support and the staffing and the skills within the beds as well. So it should provide us with more flexibility in terms of cohort of patient, and more flexibility in terms of being able to manage a slightly more complex cohort than they are currently working through. I think a couple of other things just to say, it is heavily reliant on recruitment, this plan. It's 149 staff, and that recruitment is just going underway now. So I think it's worthwhile the board being aware. I think you said ahead of winter there. I mean, firstly, where is winter in terms of what that looks like? And secondly, realistically, given that volume of recruitment, probably the earliest point in time at which this will be up and running will be November, December time. So I think it will probably ahead of winter, I think is probably a little bit optimistic in that space. But obviously there will be some incremental points along that recruitment journey at which there will be additional capacity or additional flexibility in the cohort. It's being managed both through the System Coups group, which Faye obviously sits on, and it's also being managed through the ICANN delivery board. And I know system chief execs are going to be really interested in getting an update on how that's progressing, because it is not a plan without risk. Finally, I think the other point around creating better visibility, as Debbie says, there will be people from community in the discharge hubs, but we're also working with the Northamptonshire Analytics reporting platform to make sure we've got a clear system dashboard that will provide us visibility of capacity in the different services, and that is built on the data that is patient level data in terms of understanding, you know, where are the beds, where are the patients, and what does that flow look like, and it will give us much better visibility of performance and outcomes, so we should be able to monitor it as and when it goes live. And I can see Richard is just asking me to explain some acronyms. So ICANN is our Integrated Care Across Northamptonshire programme, which looks at providing better care and outcomes and looking after people in their own home for frail and over 65 patients. And Coups is our chief operating officers across the system. So Faye, Palmer, Jean, and also our directors of adult social services are on that call.
Thank you, Becky. I think it's fair to say that the plan is not quite nailed down yet as well. And although it's a very good plan, it's not without its risk. And clearly, risks not just about failing to recruit, but risks about recruiting from places we prefer them not to recruit from. So it is a very complicated plan and quite a large investment to defragment a very fragmented service. So it's certainly a good plan, but it's one thing to have a plan. It's another thing to make it happen. Lisa.
Hi. 2 points really. ICANN and preventing admission. I'm assuming that the specialist care centres are aimed to prevent admission to the hospital question. And if so, what impact do we think they have? And do they count to our virtual wards that we're expected to do? But my main point was around Deborah's comment that the attendances at A&E, or the major rise in attendances at A&E, what in the minor category. And I'm wondering what work is being done as a system to improve people's access to general practice, urgent care centres, alternative, or if access isn't an issue, the perception, because nationally I know there's a lot of noise that people believe or truly can't get an appointment with their GP, and therefore A&E is open 24/7, so turn up at our facilities. Thank you.
Yeah, thanks, Lisa. Access is definitely an issue. What we are doing, I'll tell you what we're doing internally and then as a system. So internally, when colleagues are back in the trust, please do have a pop down to A&E and you can see the new entrance area where we've got iPads where our walk-in patients will be able to be navigated to the right place, and that's all done digitally now rather than via a nurse. There is definitely more to do with regards to Corby Urgent Care Centre. We are still finding that patients are not going there. They are coming to us more often, and waiting times generally at Corby are much less than they are here at Kettering. I'm working with the place director for the North at the moment, and we are working on how we can get better access to GPs. This is going to be slow. When you speak to GPs, and I've spoken to quite a few in the last few months, they are also full. So access for the public is definitely a problem. I don't think there's going to be an easy and a quick fix. I think what's really important here is for us that we continue to make sure people are streamed to the right services. They use Corby. We'll be doing as we come into winter. And when I talk about winter, I do mean when it starts to get colder, even though the pressure is quite severe at the moment, the activity pressure. We'll be making sure that we're communicating with the public, lots of signage before you get into the organisation, lots of signage and work across the system on communication with patients about the right places to go. We do know that that does have a small impact in Northamptonshire, so we'll be working on that as well. I'll probably let Becky answer the one around NHFT and some of the admission avoidance work that they're doing. Becky?
Yeah, thanks Debbie, thanks Lisa. So I think on the point around pathway 2 and step up beds, absolutely both the community hospitals and the specialist care centres should be doing step up to try and avoid some of the admissions into our hospitals for people who don't require that. The reality is at the moment that is extremely few and far between, predominantly actually because of capacity issues that they have. So this should help improve the flow. So alongside the additional beds, it's also intended to bring down the length of stay within those beds within the community. And then the intention as a system is to ring fence some of those pathway 2 beds for step up capacity, because we know that that would be better for people than being admitted into the acute. So yes, that is the intention. We're not there yet as a system in terms of having that step up capacity. There are a number of admission avoidance schemes that are being worked on by NHFT in particular through the Ageing Well programme, which is aligned to ICANN. So looking at how can we make sure we have frailty MDTs for those patients in the community. There are a number of balance classes and fitness classes. There's a new heart failure pilot which is just about to go live next week. So there are a number of different schemes that are there. There is absolutely more to go at in the admission avoidance space in terms of making sure we've got that capacity both more broadly and then for specific clinical pathways where we know that people are coming in. So it is a work in progress. There's an enormous amount of work that's happened, but we're not yet seeing all of that come through, and particularly in the context of having had an increase of 7,000 over 65s in the county in the last 3 years. It's not yet having the impact that we would like to have on the front door.
Yes. that little reference at the end was to the first cut of the census data, which I think is quite alarming in one sense. I mean, simply around demand and the elderly population and so on, which we'll be coming to. I think the centrality of the ICANN program, Becky, probably means we want another run through it at one of our development sessions, giving you time to deliver some of this. So maybe October or just before Christmas would be a good time to see where we stand on this. So if you could make a note of that, that would be helpful. I think you're all aware of the national press coverage of the shortage of GPs, and Northamptonshire isn't any different, and the number of GPs going part-time, reducing their hours, whatever. But there's no doubt we are, in some cases, becoming the carer of last resort, and that's not a place an acute trust ought to be. We're also affected, of course, by our neighbours. I live in a part of the county where you'd normally go to a neighbouring hospital by ambulance, but I had a neighbour who needed an ambulance admission and was told they wouldn't be going to the normal hospital because there was a 6.5 hour handover delay, but we'd be going to Kettering because there wasn't any handover delay. Good, well done, but you see the consequences. So those things all add up in terms of what Kettering copes with coming through the door. And I know our ED leadership has worked incredibly hard to keep emergency, keep ambulance transfers down, and occasionally get a bit frustrated by the consequences of that. But that's where we are. And we do need to work very hard through the Integrated Care Board, hopefully with some urgency to address these issues. Right, thank you for all of that, very helpful. Integrated Governance Report and Board Committee summaries. We're a little bit over time, so if you could, as ever, keep it tight on what you wish to draw the board's attention to. Debbie, with that gentle instruction, perhaps you could compare the next session.
Thank you. I will do my utmost. So we will go straight into the committees of the board then, if that's okay, starting with Quality and Safety Committee. And I don't know, Chris or Lisa. Lisa, I think you were covering this off.
So happy to cover. I wasn't sure if Chris was going to cover since he's here. In the last two meetings, we've covered a number of issues, one of which is mortality, which has been raised through also a national report, just to assure the board that there is work going on in all aspects of this. And we've got an extra meeting next week to look at the causes of that, but also to say that we've also got a strong assurance process behind that, in that every death is reviewed by our medical examiner to look if there were any failures of care or any avoidable factors. And that is a really strong process that's giving us no cause for concern. So that's important to note. Complaints improved, and last month, because of the extreme pressures, decreased. But again, we've got confidence there's a good process and people understand the issues behind it. Just to note that we also received the health and safety report and the final quality, and that we expressed concern following on from the previous conversation in emergency and discharge, which was around the really high occupancy, which I will quote Chris, is the single indicator about the quality of care in a hospital, and urge everybody to work hard to reduce that. The final thing was we just had on digital, I believe, the digital committee to look at the availability of software which would allow us to copy the excellent work that Northamptonshire General have done on the deteriorating patient. So, thank you, Debbie.
Thanks, Lisa. Chris, is there anything you wanted to add?
Everything's been covered, and especially our thanks to the ED department who have come through such pressure.
Yeah, thank you. Rabia, anything from your point of view, please?
Debbie, I just wanted to add, so thank you very much, is that we've just received our latest mortality SHIMI figures yesterday, and SHIMI standard hospital mortality indicator, and it has shown a significant drop in the mortality rate, but that just to assure that we carry on with all the deep dive and work we are doing to try and improve it and maintain it. So I just wanted to bring that to board's notice, that the recent figures, because these figures are 3 to 6 months in arrears, so the work we started in January is probably just maybe making its impact. Thank you.
Thank you. And Fiona?
Thank you, Debbie. I've got nothing else to add. Both meetings, there's a healthy debate and challenge. So I think that's reflected in the feedback, both written and verbal. Thank you.
Lovely, thank you. If we take questions at the end, so let's move on to performance and finance. And Damien, please.
Yeah, hi, thanks, Debbie. Good morning, everyone. So yes, a few key things to highlight. Some of the operational performance metrics that we look at in each and every meeting have consistently not been met for a while now. To name a few of them, RTT, the 62-day standard for cancer referrals and diagnostics. We took assurance that recovery plans are in place and that people are working hard to improve the performance against those metrics. But I guess ultimately, we need to see the performance tick up in the committee to feel totally assured that the recovery plans, etc., are being effective. We also noted that activity levels are lower than the plan assumed. So, for example, elective activity year to date, I think, is 99.7% against 104% assumed in the plan. And there are reasons for that. So COVID impact was talked about, as was the transformation plans perhaps not delivering their benefits as rapidly as had been assumed. So, we've heard about theatre productivity this morning already. So I think, again, we want to keep a watching brief on that to make sure that the transformation plans are delivering the benefit that we assumed, and therefore the planning assumptions will hold as we move through the year. On the money side of it, there was a 1.1 million adverse variance year to date against the planned deficit of 6.04 million. I think, John will talk to this, but probably too early to start drawing any conclusions. It's month 3 of the financial year, but quite possibly related to the activity levels being lower than planned. And I think, again, we need to keep a kind of watching brief on that. And I think John will say take a view at the half year point as to how well the financial forecast will hold together. A couple of other things to note. We approved the business case for additional funding for the electronic patient record system, which I think we all agree is vitally important to the digitisation of the trust. We also approved a business case for funding to develop an outline business case for the Midlands and East 2 pathology network work that's going on at the moment. So those are probably all the key things I wanted to cover, Debbie.
Lovely, thank you. Faye, anything you'd like to add?
Not at this moment in time, because we have an ops report later on in the agenda. Thank you.
Yeah, thank you. John, anything for you?
Thanks, Debbie. So yeah, just to give a little bit more colour and detail to the conversation that Damien added. So of that kind of variance to plan to date, the 1.2 million, we are 1.6 million, i.e. greater than that overall variance to plan, lower than income, because we have not earned elective recovery income as it's been planned for. So that really is the kind of big item, there where we've not hit delivery, we've not met the same levels of activity as we had delivered in 1920. There have been, and just so I kind of tell the wider story, there has been a step up in our spend in temporary staffing in most recent months, and that is entirely to be expected given increases in unavailability of staff, sickness, COVID, and all of the other challenges that colleagues have described. But just to say they are having a real impact on the money and the numbers. I need to brief the board that we were told about a week or so ago now that nationally there will be a reintroduction of agency caps, i.e. now at a system level, we will be expected to not spend more than a certain amount on agency staff. It was expected that that might cover bank as well, but the guidance that's been sent out is agency only. Those caps come into place from September this calendar year, and the expectation is that we reduce our spend in agency compared to last financial year by somewhere between 10 and 30%. To put into context where we are to date, at the end of month 3, we would be, compared to the KGH spend, the average KGH spend last year, we would be pretty much in line with, i.e. within kind of tens of thousands of pounds in line with last year's spend for the first quarter. So we wouldn't be significantly higher, but we would not have seen that reduction. So clearly some work to do there with colleagues to work out the deliverability of that plan. We've got an agenda item in terms of the wider plan and assumptions, but it would be remiss of me not to say that the plan that we set for ourselves with quite significant direction from NHSEI colleagues assumed low to no COVID and assumed no major impact on flow or other challenges within the hospital. That clearly is not the operating environment that we've been working in over recent months. That aside from the quite obvious operational challenges that we have, and the fact that we aren't treating patients as quickly as we would like, clearly that's playing out in terms of the money. The ask on the money in terms of our plan, you'll see it in the papers, does step up. It steps up in quarter 2, the challenge, and then it steps up again as we move into quarter 3, halfway through the year. As Damien has said, the Finance Performance Committee, or PFR, I stated that we need to do some structured work over the coming weeks and months to understand where quarter 1 has now left us in terms of moving forward. And what that means in terms of risk and deliverability of that overall plan. As Damien has said, direct quote, it's too early to call. But I think the challenge clearly on us is to kind of, with some quite legitimate and difficult operational challenges on managing capacity, we now need to kind of redouble efforts in terms of the speed and scale of improvement and productivity changes. And we need to be able to both explain, quantify, and demonstrate that we've done everything that we could possibly have done within that changing context, because the level of scrutiny on us, both from system partners and from oversight bodies and HSEI, is going to be significant. We're not, I've got no doubt that we'll be the only organisation in this place, but part of the narrative is, do we understand what's changed and why, and therefore quite reasonably, what are we going to do about it, and how does it compare to what we had originally assumed? So I'll work with colleagues to step through that in board committees over the coming weeks and months, but really we need to have got to a conclusion on that before the end of quarter 2.
Thanks, John. Let's move on to people. And Lisa, I think you are covering.
I am. Good morning. So the theme of both the committee meetings really was one of looking at the resource pressures being put on the hospitals. Debbie's already alluded to some of the operational pressures in her opening section in terms of the extra COVID and the extra demands on A&E. But really in the people committee, we looked at those from the people aspect, trying to understand what that was doing to staff morale and their effectiveness to do their jobs. Some particular area of focus was really around COVID, where we talked about the removal of the COVID sick pay and really trying to understand some of the unintended consequences of that, and to ensure that we monitored the risks that would pose to the hospital, to ensure that we continue to abide by the correct policies in terms of protecting the staff and the patients, but also making sure that we got the correct staff in order to fulfill the rosters. We also talked about the recent pay sector award. To be honest, the session was a little bit too early to fully understand the consequences of that, but but the committee noted the need to understand and communicate that to all staff as quickly as possible. We also then spoke about the impact that the increased collaboration between the two hospitals was having on some of the staff, really trying to ascertain how best to intervene to reassure and provide some guidance to all the staff about those changes and how it impacts them. And I think finally to note, there were a few housekeeping items which are written in the notes in terms of looking particularly at the new risk register and some of the new policies in terms of the way the committee would meet. So I'll end it there.
Thanks, Lisa. Mark, is there anything you'd like to add?
Just a tiny bit, Debbie, at least covered it off, of course, but I think there was just one thing in terms of it's the uncertainty of change. I think that's the thing that people are impacted by, and particularly in the cost of living position that we're in, people are worried about potential redundancies, etc., and the cost of that change, if that makes sense. And I think we just need to continue to reassure colleagues that that's not necessarily the space that we are in. I think we also, from a wellbeing perspective, more from a financial wellbeing perspective, we also were able to share some of the initiatives that we've been able to put in place quite quickly, such as bringing salary forward for people should unexpected bills come in, etc., that they needed to address before payday, if you like, on a monthly basis. But that's it. Other than that, thank you very much.
Thank you. Let's move to digital then, and Alice.
Thank you, Debbie. Just a few things to draw out from the report. We had an extra meeting this period because we just had a lot of things on the agenda over the summer, and we wanted to make sure we gave those appropriate time for focus. There's a little bit more to talk about. Firstly, it's a Northampton issue, but I think it's highly relevant to Kettering, so I will mention it. The NGH board yesterday approved the opening business case for their EPR system, highly relevant to us because of our collaboration work and everything that's been intimated at today, that the sooner we can get both of us on an electronic patient record that can talk to each other, or ideally even is exactly the same language, then the sooner we can move forward on our areas of clinical collaboration more effectively. So that is very, very important that stage has happened, and that's now gone off back to the regions for approval after that. To say on that, that we are in the meantime trying all the means we can to accelerate the pathway in other ways other than going through the full tender process, and to look for whether we can direct award, and very much trying to keep that door open. We are struggling to achieve that at the moment, but we're very much trying to keep that door open. And in the meantime, also looking for ways, particularly in the specific areas where clinical collaboration is accelerating, looking for ways we can put in place solutions in the interim, if you like, to allow that clinical collaboration as much as is possible. So it's a real focus of the digital team at the moment. I also was going to mention, it was mentioned earlier, that we were very glad that the servers survived the heat last week. We know that Guy's and Thomas's definitely didn't survive the heat and had some really catastrophic issues there. So whilst we take no glee in that, it was good to know that we survived, and we continue to look to put systems in the cloud so that we're even less vulnerable to those sorts of infrastructure issues, be they heat caused or by any other external issues that we have going on. The more we can do that, the more resilient we are. The other thing I think it's worth flagging is we had a session with our CCIOs. They are our clinicians who are tasked with specifically spending time talking to the clinicians around digital implementation and feeding back and forth between digital and the clinicians on needs and progress and projects and so on. So we had a really useful session with them on where we think we are on engagement with those clinical teams, and particularly took some actions forward from that to how we can enhance that, which, if we're honest, we know perhaps hasn't been quite where we'd want it to be during COVID. As a result of that, I've also spent some time with some of the clinicians that are using the new electronic documents that are online now for the patient record in KGH, and have been reassured that although there are a few teething issues with a couple of clinicians around use of those, that on the whole, they are working well. They are not a final step because they are scanned copies of paper as opposed to digital from start to finish, but they take us a significant way in removing the need for those paper files to be bussed around our hospital. And they are already seeing a significant saving of clinical time in waiting for those documents to come. So a significant improvement, and it was really good to see that in practice and a really significant step on our journey We also had a sit down with the governors. The governors had fed through a number of their recent meetings, a number of questions around digital, around the strategy and around implementation and so on. And myself, Andy and Tom, the digital director at KGH, had a session with them last week where we sat, listened to their questions, answered as many as we could. We've agreed we'll have another session in the early autumn to carry on that dialogue and to keep those channels open so that they can help us in rolling out those digital messages and in us listening to what they're hearing is working, what isn't working. So I think that is all, Debbie.
Thank you. Okay, let's move on then to CPC, and I think we're still with you, Alice.
Yeah, absolutely. For now anyway, and then next month I think we can hand over to Lisa for this. We're in a process of transition with the CPC. Up till now it's been focused on I guess kicking off a lot of the group work that's been going on. Its remit's going to slightly change from next month, which is our September meeting, and we're not meeting in August. It's going to become also a body for overseeing the transformation agenda, and Lisa Yalf is going to be taking that forwards as chair. So just quickly to update on what we've talked about recently. We spent quite a long time at the last meeting talking about the Cardiology Centre of Excellence work, and particularly understanding some of the challenges that's entailed recently, and giving, I guess, our support to the cardiology team in dealing with those challenges. And that was a really useful discussion, and I think was probably quite characteristic of some of the challenges we're having in clinical areas where we seek to collaborate, which are things we're going to need to deal with in any areas we seek to collaborate in. So it's really good to be able to have a frank conversation about that and give our support to the team, but also to understand some of the exciting things they have planned and the difference that's really going to make to our patients in the county. So really very much proved the case for me of why this is worth doing, and it's worth getting right and doing well. We also spent some time looking at the theatres work, which I know we're looking at further down the agenda, around both the list management and also the theatre sufficiency project. And we looked recently as well at the sustainability agenda, the work that's going on, particularly around KGH and the Energy Centre there as well, and a few other matters that are raised in the written report. Thank you.
Thank you, Alice. Lisa, is there anything that you'd like to add on the transformation side?
No, just looking forward to the transition of the committee, and we'll report out next time.
Lovely, thank you. Becky, can I invite you in to talk about anything you'd like?
Yes, similar to Lisa, I think it was a really good first outing of some of the transformation work in terms of theatres, and we can carry that conversation on today. And yeah, looking forward to talking more about transformation with everyone in the committee.
Great stuff, thank you. Let's move to audit then, and Trevor, please.
Not quite seamlessly. So the last meeting was one of our big meetings of undertaking work on behalf of the board. We signed off the letter of representation, the annual accounts, the annual report. I must add that this was a significantly better dialogue with our external auditors, Grant Thornton, this year. John and his team have done a lot of work over the last 12 months around that. And I think we have a much better relationship going forward in that regard. We also, I should say, it's not part of the report, but the relationship with our internal auditors, TIAA, and I'm not going to go through what that acronym is, they're just known as TIA, has improved such that we've got them undertaking, and it sounds odd, undertaking the internal audit for this year right from the beginning of this year, rather than picking up the pieces from the previous year that they hadn't finished. So the relationship is such that they hit the ground running this year, and that in itself is good because it means we will get a full worth out of them, but in terms of reports, recommendations, etc. And finally, I think we had a good discussion around the draft code of governance that has been published for consultation, and did some feedback on areas where we felt that from the KGH perspective, the draft wasn't in line with what we thought ought to be the new code of governance nationally going forward. Thank you.
Thank you, Trevor. John, anything to add?
Only to add, Debbie, that our external auditors commented to the audit committee that the accounts that were presented were a good set of accounts. that doesn't happen often, and that doesn't happen without significant work. So I think it's worthwhile bringing that to the board's attention. I think that's all positive, and Trevor's already referred to the kind of relationship stuff, which again we've spent significant time and effort on with our external audit and internal audit parties, willingly to get to a better place. Hopeful that will continue. We did not take to audit committee our value for money assessment that's also carried out by our external auditors. That's because the deadline for that piece of work is September. That work is ongoing, in progress, and will come to the committee for review. So the kind of accounts and annual reports being the big pieces of work, but also our value for money assessment, essentially how effectively we've used our resources and kind of broader governance arrangements. That will come to the committee in September in line with national deadlines.
Thanks, John. And finally, Strategic Development Committee Chair.
That'll be me then. Well, you've already had reference in Debbie's report to the electrical infrastructure during the heat wave. So just to bring you up to date, we've put in the final business cases and so on for the whole redevelopment and the HIP2 programme, the Hospital Improvement Programme at Kettering. And after that committee, we had a visit from the Secretary of State and his team, quite a large team actually, on last Friday, which went very well, and we should thank our 3 MPs locally for turning up for that and helping to lobby the Secretary of State for the work we were doing, particularly around the infrastructure, the heating plant and the power plant and the power supply to the hospital. And at the end of that, I'd be more optimistic that the monies for that, which we call enabling works around the new hospital programme, will be more likely to be forthcoming in the near future. And it's always good to have our MPs involved in those meetings. So those business cases have now been received, and we're expecting some decisions in August. And of course, that's quite important because political leadership is uncertain after the 5th of September. So it's important if we can get that through the process whilst the current political leadership is in place, which may continue or may not. And just as an extra, it's really an NGH issue, is that they've won a £20.5 million bid for infrastructure projects for a green agenda down there. And whilst that's very much an NGH issue, of course, it does potentially free up some resources across the group for thinking about what might happen in KGH, but it also gives us a sense of expertise about what might happen in KGH after the NGH work. So a little bit of, the benefits of collaboration, which we occasionally preach about. But all in all, it was a good process. We also had a session on community diagnostic centres, and you'll be talking about that in the private part of the board. And once again, the perennial problem of car parking, where obviously, as we start to rebuild the hospital and those plans go forward, the existing car parking comes under threat due to the scale of the new builds. So some interesting and important thinking about how we might increase and retain car parking across the site during that, what will undoubtedly be a very disruptive and difficult period. Polly, did I miss anything?
No, you didn't miss anything at all. Aside from to say, I just wanted to thank our staff as well in ED and elsewhere for the effort they put into the Secretary of State visit and touring him around. That they showed him a very good visit, and I've had feedback from the deputy or from the coup of NHSE to say how much he enjoyed his visit to our ED department. So our thanks to our staff for putting that together.
Yeah, thank you. It was a good visit. We had no ambulances waiting. We had a busy department, and we had a consultant and a head of nursing who answered every one of his questions crisply and efficiently. So that worked extremely well. Yes. Okay. Joint Thank you very much for that. Is there any questions on any of the points raised in any of those reports? No. Okay. Thank you very much. Item 6, ICB submission. John, Karen, I think it's Karen kicking this off, is it? And then John or the other? Yes, right. Karen, over to you.
Thank you, Chair. I just wanted, I'll take the paper as read, and also I'm very conscious that there's been some detailed discussion about the operational plan and the resubmission of the plan through various committees and also CPC, and there's been separate workshops on it with non-exec directors and exec directors. So I just want to pick out a couple of the key points. You'll be aware that we submitted our initial plan on the 28th of April, and all systems were asked for a resubmission of the operational plan by 20th of June, which we have done as a system. And one of the key asks is to deliver obviously the performance targets that we had submitted in our initial submission, deliver a recovery of our backlogs and improve our waiting times, and treat our patients, start to treat those patients who've been waiting a long time by increasing our activity to meet 104% of the 1920 original plans. Delivery, sorry, and also financial break even. So the real difference for the 20th submission of June was the financial break even. So what we have done, I just want to draw out a couple of key points in terms of assumptions as well. The assumptions have remained the same, and we've started to talk about those today in terms of how those are playing out. But the assumptions of the plan have remained as low COVID levels, limited impact of our non-elective demand and flow issues. And we've started to see what that's really doing in terms of delivery of the plan, but those assumptions have remained the same and were included in the plan. Sorry, can you hear me clearly? Yep, okay. So what we have done is, as a system, we have submitted a plan, and we have submitted a break-even plan, which does pose, and collectively we've agreed the financial plan with all parties and all providers taking some risk, and it does pose a major challenge for us as an organisation and as a group, and we've started to talk about some of those today. One of the key things that we have, the changes are that we are required to increase the financial improvement across the group of 20 million, which is 11 million for Kettering. John has started to talk about that, and other colleagues in terms of delivery against that in the finance and performance finance and performance committee. But really key is just to note that that's the plan that was submitted, and it's the plan for this year. We're not looking at longer term financial plan yet. That's what we need to do now, because we need to start focusing on sustainability of this and how we can deliver for remaining of this year, and also going forward how we take that forward in terms of our longer term sustainability and recovery of our waiting times and support of our patients locally. So I'll pause there, because I think that just is what the key issues are that have been included in the paper. John, did you want to add anything specifically? And then happy to take questions.
Yeah, if it's okay, Karen. So just to say that in terms of kind of system dynamics and joint decision making, I think this is a really good example of us kind of working really collaboratively to get to a joint aim. It is not a foregone conclusion, nor given what I've been told of other colleagues in other systems, the case that other systems have been able to sit in a room and jointly agree risk. I think we've heard in the board meeting already today a number of kind of tactical decisions on capacity, pathway change, resourcing across the system that we are jointly agreeing to, and different parts of the system stepping up and agreeing to play their part in leading that. I think that's all very positive. I think the fact that we've managed to get that over the line in terms of the plan, that's positive as well. Clearly, there are significant challenges to delivery, both in terms of implementing those tactical changes that we've agreed, but also the really quite challenging assumptions that we've been asked to work with. The relationship is there. If it wasn't there, we'd be in a far more difficult position. Clearly, the challenge is making those difficult decisions and delivery. The other thing to pick up is, and Karen's alluded to it, is this is a kind of 1 year plan. We are going to be asked, it's expected, to start putting together a multi-year plan beyond this year, potentially this side of Christmas. That is going to require us to be far wider reaching in terms of those initiatives that we look at across the system, in terms of bed flow, in terms of reducing attendees, in particular our acute hospitals. And again, being able to get into a position where we've got those agreed change programs that we understand, that we've got buy into, and that we've quantified and actually understand the impact of, I think is going to be really difficult, but clearly that's the ask. So relationship wise, I think quite positive. But in terms of, and we could be in a far worse place. Clearly, the challenge is now to put in place those programs that we have agreed or committed to deliver, and then work through what that means as we move into a far wider strategic piece of work to make the system both operationally, kind of financially and clinically sustainable.
Okay, thank you. You've been through this loop a few times, and the world keeps changing, as we know, but that's where we are on the plan that was submitted, and that's the baseline against which all the changes in the assumptions will be made and argued. But we're also aware of the political leadership issues nationally and how some of those things obviously would be not properly resolved, not appropriate to be resolved in the current semi-interregnum. So there will be some issues that NHS England nationally will find a little bit difficult to handle, and certainty will be hard to come by in the near future. Any comments or questions on that at all? I don't see anything. Do I? Yes, Trevor.
Thank you, John and Karen. I think the thing for me, which is it's not about a communication issue, but it could be, if we're not careful, looking at the activity information we've got to date elsewhere, the issue of 104-week waiters and the fact that we are actually taking on cases from other hospitals. I'm not saying other counties, because I'm presuming some of these may actually be Northamptonshire patients. Actually, it's how that feeds into a system-wide reporting rather than necessarily focusing in on the individual trusts. I don't know what thought's been given to that.
I mean, I'm happy to pick up the first bit, and I'll defer to Faye probably in terms of the operational performance and that detailed stuff. I mean, we have been given quite explicit guidance that says patients that transfer via mutual aid, which is the term that's being used where we take on patients to support waiting lists and provide care earlier than they might otherwise receive it at the hospital they're currently at, that those will be excluded from our numbers from a performance point of view. I think nationally that is still being worked through, and essentially we're going to have kind of two versions of the truth. One of our patients, in inverted commas, that have always been on our waiting list, and then those numbers of patients that have moved over to us so that they can receive more timely treatment. I think that's still in development, both internally within our hospital and then system wide. I mean, not all of the patients are Northamptonshire, is my understanding. A large number of them are, but as we are looking at this and providing support, given our comparatively much better kind of waiting list position compared to other systems locally, we are being asked to take on patients that are not Northamptonshire patients. Clearly, we're part of an NHS, not just Northamptonshire, and where we're able to, we need to provide that more timely care and support to patients that would otherwise need to wait longer for treatment. So I think in terms of the approach, it is, we'll do it exactly what we can. In terms of the reporting, I think we've got a little bit of a way to go to provide transparency there. I don't know whether we've got a kind of that was certainly my assessment as of a couple of weeks ago. Are we kind of anywhere closer to having that resolved, Faye, I guess would be the question.
Yeah, thank you, John. You'd think mutual aid would be a simple concept, but it's far from simple, particularly when you get asked by places on the far west of the country to help provide help for them. And then far from simple about how you report it openly and properly. Faye.
Yeah, thank you, Chair. So just briefly, from an operation point of view, Trevor, we've only taken 35 patients from Leicester. So we have actually screened 130, but due to complexity or the patient wanting to accept, we've only actually had 35. So it's not huge numbers. However, that is 35. That is 35 slots, if you like, through our theatres. I guess going forward, we are going to be asked to meet the next trajectory, which is no more patients over 78 weeks by the end of March. And I'm in no doubt that we will be asked to support Leicester. From our perspective, we don't have any 104-week waiters. So for me, it's not necessarily about yes, it's about the reporting, they'll be excluded, but it's also the impact it has on our capacity, which is key in terms of our trajectory, if you like, to get us back to, 18 weeks would be brilliant, but, no more 52 weeks as a starter for 10. Thank you.
Debbie.
Yeah,
and
thank you.
Sorry, could you answer Lisa's question in the chat?
Just about to do that one, yes. So yes, the activity is absolutely ours. The patients transfer across to our waiting list, Lisa, and the activity is ours. So it does count towards the 104%.
Okay, thank you. I mean, of course, the issue is that patients have waited a very long time. So we almost have to start the process again in terms of exactly what procedure they need, exactly what state their care is in and so on. And it has proved extremely difficult, and that pressure will continue. That's what the N in NHS is about, but of course it does have a consequence. And I know our governors from time to time get exercised about the consequences of this. And indeed, not all the patients are from Northamptonshire, some are from a distance away. Okay, thank you for anything else at all on any of those reports? No. Okay, thank you very much. We've reached coffee time, 11:02. Back at 11:12, please. Enjoy the short break, 11:12. All right, 11:12, we should all be back. And we're on what is kind of the focus for the day, really, around efficiency, operational focus, including this year's activity, particularly year to date, around big public concern issues like ambulance handover time and the pathways that go with that, and elective and cancer delivery. So, bit of the Faye Gordon show. Over you go, Faye.
Yeah, yeah, thank you, Chair. So
you don't sound as if you're thanking me.
I'm not really thanking you, no.
Yeah,
Okay.
I didn't think you were grateful. Anyway, press on.
Okay, so I'll start with elective recovery, if that's okay, given the previous conversations we were just having. So as others have mentioned, we were asked to submit a plan that was 4% above pre-pandemic levels, and there were a number of assumptions that were made as part of those plans. And I think it's fair to say the teams worked really hard to get underneath why we delivered the plans we did in 2019-20 and what could we deliver this year. So there are a number of assumptions that sit behind these plans, some of which we've seen to come to fruition and some which haven't. So for example, in ophthalmology, we're anticipating 2 more consultants starting. We had appointed, but then they failed to arrive. So that's impacted on our plan. The other reason is COVID, and we've seen a number of staff and patients cancel, or we've had to cancel lists because we just don't have enough staff on the ground to deliver those theatre lists. So within the slide deck that's been provided, you can see that there's a number of specialties that are not quite hitting the numbers, and there are particular specialties, for example, ENT, oral surgery and pain management, that are way below where they need to be. And these are the particular specialties that we're really focusing on. What we also know is that the theatre utilisation isn't where it needs to be either. So clearly there are some opportunities which we need to focus on. But as you can see from an elective point of view, it all sits very much in the surgical division. So one of the pieces of work that we've asked the divisional teams to do is a deep dive into all of those specialties. And as John alluded to earlier, it's really important that we understand why we've got the gap, right down to the detail, because what we need to understand is where we're going to land in the next few months. So the divisional teams are undertaking this deep dive, and the plan is that they will bring those plans, or I will take those plans to Finance and Performance Committee next month, with a view that we have a really clear plan and trajectory. And obviously we also need to have a plan around how we're going to pull back the numbers that we've not delivered to date, whilst also delivering what we need to going forward. It's not just too dissimilar in an outpatient perspective. Again, we're quite clear on the specialties that aren't quite hitting the mark, cardiology being one such service. And the reason for that is very much around the extra capacity we needed to provide those additional clinics. So we've recently got some additional capacity at Woods End. It's taken a little time to get that on board, but that's now there. So we're expecting to see an improvement in cardiology outpatients moving forward. Both from an elective and an outpatients position, we have seen increases month on month. So we just need to keep going with those trajectories. But like we've discussed earlier, it's really important we understand why we are where we are and what we're going to do to rectify that. So diagnostics plan was set at 120%, so 20% above what we were delivering in 1920 levels. And you'll see from the slide that I presented, we're just shy of 100%. So actually we're doing pretty well in terms of diagnostics from an activity perspective. That said, the plan is set at 120, so there's more that we need to do in that space. We have, again, lost some capacity down to COVID, particularly at our Woods End, at our Woodlands facility, which we share with the private provider. And we lost quite a significant amount of capacity in June due to COVID impacts of staffing. So again, we're working with the Woodlands to see what we can do to pull that back. So I think in summary, we know we've got to we know we need to understand why we've got a gap. We've got some issues, as you heard earlier, around availability of theatre staff. Now that is pretty key if we're going to pull back the gap, particularly in elective surgery. In June, we had a 42% unavailability, and that was due to a number of reasons. And as Rob alluded to earlier, there's a huge amount of work going on in terms of recruitment, and there's recruitment days, and they're looking at all sorts of creative ways to be able to bridge that gap. But there's definitely more to do in that space. Becky will also talk later around the transformational programme in theatres that we're working on. And I think, this does give us huge opportunities in terms of the sessions that we've got available and really maximising the time that we've got available to us. One of the key elements of that is the theatre scheduling tool. So how we schedule and book our patients. We had hoped that would be rolled out and in place by the end of June, but that's not quite happened yet. But I'm working really closely with Becky, and we're aiming to get that in place and rolled out across all of the surgical specialties by the end of August. So that's elective recovery. If it's okay, I'll carry on with the rest of the operational report and then come back for questions, if that's okay. So from an ambulance handover point of view, you would have seen in the media that the pressure that our ambulance colleagues have been under, particularly in terms of response times, and how concerned we've all been, and the government have particularly been, in terms of handover times and patients being left in the community whilst waiting for an ambulance. So I'm pleased to say that KGH actually fares really well in terms of the handovers, the handover times. You will see from the report that we have and the IGR that we have very few 60-minute breaches or patients waiting beyond 60 minutes to be handed over, and we really do pride ourselves on making sure that we deliver that, because it's so important for making sure that patients, that the crews are turned around and they get back out to those patients that are most needed in the community. It doesn't just happen on its own. The leadership that we have within our ED department is exceptionally strong, and that really is down to Ali Gambi and to Adrian, our clinical lead, who really are committed to supporting the need to get our crews back out onto the roads. But we have been under pressure, particularly this month, particularly because of the heat wave, but also our COVID numbers have gone up significantly, as Debbie mentioned earlier. And that really does have an impact on the flow through the organisation. So for the first 2 weeks, or for the last 2 weeks in July, we've had to open an additional 38 beds. That has not been easy, given the amount of staff also that have been off sick. But the teams have worked really hard to make that happen, because that is the commitment as an organisation we have to making sure that we have timely handovers so that the crews can get back out on the road as quickly as possible. So just to say on the final note with that one is that we've now actually been able to close all of our escalation ward. So 38 beds were still open on Tuesday and Wednesday. But as of last night, we've managed to close all of those areas, which is really, really very good news for our staff on the wards. So from an elective performance point of view, just to give a quick summary in terms of what Damien alluded to. So we're doing really well with cancer 2-week waits. We had not met that target since last July, but for the last 2 months we've delivered that. So that's really, really very good news for our patients. The faster diagnostic target also we are exceeding. So the target sits at 75% and we're at 82%. So again, patients are getting diagnosed a lot quicker. Where we need to focus more of our energy is ensuring that our patients are treated within that 62-day window. And again, we haven't met that target since last July. However, the teams have a really robust plan in place and trajectory. And I'm pleased to say that in January, we had 84 patients that were over the 62 days, and that is now down to 51. Our aspiration is to move that to 35. And when we start to do that, we will start to recover the 62-day performance target. Of course, it's not just about the target, it's about ensuring that our patients are seen, diagnosed and treated in the shortest amount of time. And that is our ultimate aspiration. So from a 52-week point of view, or RTT, we're clearly a long way away from delivering 18 weeks. But what we are committed to is to having zero tolerance to 52-week breaches. We've already talked earlier about the impact of UHL, and of course, we will continue to support UHL and other organisations as we need to, because we have very few patients sitting above 52 weeks. We still have some, and we need to do more in that space, but we are absolutely committed to helping and supporting. It's really quite difficult at this moment in time to say with any certainty when we will be at zero, because we don't know what's coming downstream. However, the teams are working on a plan, and our aspiration is to have no more 52-week breaches by November 2022. So we will work towards that. We are committed to that. But obviously with COVID and the curveballs that we get, that isn't always possible. But what I do know is that if we concentrate on our theatre utilisation, we will definitely be able to treat more patients. And I know Becky will talk about that in more detail later on the agenda. Thanks. I'll pause there for questions.
Thank you, Faye. Comments, questions, thoughts? Click where. Alice, and then Trevor, and then Damien. Alice.
Thank you, Alan. Faye, just a question around the ambulance handovers. That's excellent that we are really focusing on that, and that's really good to see. And I'm sure lots of people will be interested to know how we're achieving that. But I guess I don't want this to sound a negative slant, but is that causing pressures elsewhere? If we are managing to admit people faster than others are able to do so, is that causing resultant pressures elsewhere?
you like me to answer
let's
that?
just gather a few thoughts, Faye. Trevor and then Damien.
Thank you, Faye. I think the 2 points, one is on the ambulances. I'm aware that there were some changes on the arrangements with the ambulance provider in terms of taking people to NGH or KGH. And I was just interested in terms of how much impact that's had at KGH, especially seeing as I've been sitting outside NGH a number of times recently and seen the queues of ambulances parked up waiting to get in there. So I think that's one point. The second point was ophthalmologists. You mentioned right at the very outset about we had 2 ophthalmologists lined up and they disappeared. What is it that we can do to try and make sure that, not just ophthalmologists, that when we are actually trying to fill these vital posts, that we do recruit and have the individuals coming into the trust that we need to be able to deliver these targets? Not just the targets, but provide the service.
Thank you. Damien and then Chris.
I want to constructively put forward a challenge to executive colleagues, which is along the lines of, in the 5 years I've been a NED, there have been various transformation programs, and pre-COVID, it was normally to meet some kind of efficiency target, which would help to balance the finances. And for whatever reason, they kind of systematically have not delivered to the extent that we thought they would deliver. And in some respects, you could say that's a failing of the committee that I chair for not holding the execs to account or seeing the course correcting the plans. And I'm perfectly willing to accept that criticism of chair of that committee. I just want to, pose the question as to what's going to be different this time, the kind of staying power to get those transformation plans delivered, such that we see the impact in the performance metrics in the finance. And as I say, I offer this very constructively and self-critically of the committee that I chair.
Thank you, Damien. Chris.
A question or 2 questions. With regards to 52-week waiters, if they are offered a date for admission and turn it down, how does that count in the statistics? And the second thing is, you mentioned that good work in diagnostics. Diagnostic hubs are being set up. There is a serious national shortage of sonographers, radiographers, and radiologists. How do you see the future? Thank you.
Okay, anything else at all before we go back to Faye? No. Okay, we do have a session, of course, as you know, on community diagnostic centres in the second part of the board meeting, but that doesn't preclude answering the question you've just asked in this part. Faye, over to you.
Okay, thank you. So I'll start with Alice's first question and around are there problems elsewhere? So I think it's fair to say, Alice, whenever we are, it's a balance of risk, and that's what we talk to the team about on a daily basis. So the last couple of weeks, we've had to open additional capacity. And the question is the risk at the most on a daily basis is work with the team to say, where do you think the greatest risk is? What do you think we should do? And what we decided to do in the last couple of weeks was open additional capacity, because we felt to leave somebody on the back of an ambulance, particularly in those 2 days of extreme heat, was not the right thing to do and was not the safest thing to do. So I think on a daily basis, I work with the senior teams, the operational teams, to say, what do we think? And we have to consider the staffing. And I work really closely with the medical director and the director of nursing, along with the ops teams, to say, what do you think we should do and how do we balance this? And I think our conclusion has been actually to have maybe an extra patient on the ward waiting to go into a bed versus an extremely overwhelmed ED is not the best way forward. But it changes every day depending on the staff that we have. So in terms of strategic conveyances, this is something that the Chief Operating Officer at NGH and myself have agreed along with the EMAS colleagues, because what we do know is that often the NGH do seem to be under more pressure than we are at times. And that's not to say that we're not working hard or the team aren't working hard. It's just the way it is. And sometimes our flow through the organisation is better. So what the strategic conveyance policy actually says is, if one of the trust is holding more than 3 ambulances, for example, for more than 60 minutes, then they can have a look at the intelligence that they have in front of them to say, actually, KGH have not got anything on the waiting list, if you like, the stack as they call it, and therefore actually it's safe to say convey some patients on the borders to KGH, and also vice versa. That has had to happen in the last couple of weeks as well. But I think in terms of being committed to making sure handovers are done in a timely way, and that patients are not being kept waiting either on the back of an ambulance outside one of our hospitals or at home, not supported, it's the right thing to do. And Adrian, as the clinical lead, is absolutely supportive of this conveyancing policy. We will review it in September to see how it goes, but at the moment it seems to be working well. So from an ophthalmology point of view, thanks, Trevor. Really tricky question that, in terms of how do we retain. I think ophthalmology is a hard to recruit specialty. I think it's a market out there, isn't it, for these individuals, and they're cherry picking where they want to go. I think it's one to consider, and I don't know whether Rabbi has got any thoughts on that as well, but certainly I think it's a really difficult one, and we're also struggling to get locum consultants as well. What we are doing, though, is using our insourcing partners to help provide some of that additional capacity, and we hope to work with those to bridge that gap going forward. Damien, from your question, and I know we talked at great length, didn't we, about transformation and not delivering. I'm going to be a bit naughty here, actually, and ask Becky if she's got any comments in a second on that. But I think within our trajectory and plan, we did set out to implement the pan and tier model, which I know we're going to talk about shortly, a lot earlier on than we had, and for many reasons that hasn't happened. But if it's okay, I'll continue on the last question, and then I'll ask Becky to maybe respond a little bit more around that. So in terms of 104-week waits, Chris, basically they are excluded from our count, but obviously they do count in terms of our numbers, as we talked about, in terms of our capacity. It's part of our activity plan, but they are excluded if they're UHL patients from our actual performance. But as you rightly say, there are some caveats in that. So we have offered all of our patients that come from Leicester a date before the end of July, so before the 104 weeks. There are a number of them, not an awful number, that have declined to take that treatment date, either because it just doesn't suit with them, so therefore patient choice, or because their procedure or their condition is complex, and therefore it's not been able to a decision has not come to a point that we're ready to treat those patients. So the definitions are really very clear, but what we have done is offered everybody that should be offered a date within that time frame. There was a couple of patients that have chosen to wait, that other than that we will meet that target. So from a diagnostic hub, you're absolutely right. We are currently working on a plan at the moment, particularly for MRI. So from a diagnostic point of view, we have been challenged from the 6-week point of view for CT, MRI, ultrasound and echo. We've got some really clear plans for all but MRI at the moment, this moment in time. And one of the things we've been talking to Polly about is how long is it going to take to get the diagnostic hubs up and running? And also what can we do in the interim, which means that we can reduce that waiting time. So I know that Polly and we, indeed KGH, have got access to some money, which means that actually if we can put some satellite units outside of KGH, then there's an opportunity to have more MRI capacity for our patients, which means that one, we can improve our activity plan and our activity numbers, but also start to move forward in terms of delivering the diagnostic 6-week wait. But I know Polly's got her hand up, so I'll pause there. Thank you.
Yeah, can I just clarify one point, Faye? I mean, I think Chris's question was actually, does the clock stop?
Oh, okay, sorry.
Have a date and refuse it.
Yeah, so so a clock stop. So if it's 104,
if you give them a date that's at 103 weeks and they turn it down, what happens?
So it carries on, but they're excluded. So it's we don't get penalised.
I think that was the question.
Okay, sorry, thank you.
Becky, you got that landed on you to talk about why you're going to work when nobody else did.
So, I mean, I think one of the things that's difficult about theatres in particular, and we heard the complexity of the challenge in terms of where the planning process starts and going all the way through. There are a lot of moving parts. So what we are working towards is making sure that we've got a programme that covers from the start all the way to the end. And I think there are probably 3 main things that are really needed to make sure that transformation works really well. We have to have systems and processes that work for our teams and sort of not against our teams. And I think some of our digital systems historically haven't worked with our teams. And so we've been fighting around the process. The Trust CCS solution, Faye's quite right, it is slightly delayed in terms of implementation, but we're now about 2 to 3 weeks away from having all the information in and being able to go live with all the teams. That will really help in terms of visibility and making it much easier for our teams to work with a system and not against it. I think making sure the whole pathway is considered. Obviously, some of the pre-COVID theatre productivity programmes precede me, so I'm not quite sure exactly what was covered in all of them. But the programme we've got at the moment is working with the teams all the way actually from outpatient appointments. We're looking at how we can join it up with the outpatient through the pre-op assessment, through the e-consent. We've been fortunate with the TIF funding to support some of that, all the way through. And I mean, you heard about the SSD work as well, and then all the way through within theatres. So it is a big challenge, but we have now got a programme that covers that whole spectrum, and importantly also brings up staffing and training, because ultimately making sure we've got the right staff with the right skills, that can often lead to productivity challenges within theatres as well. And then the final thing I would just say, I think it's really critical, you know, obviously my team are supporting, but it's really critical that it's led and owned by our clinicians and by our divisional teams. Rob has obviously recently started in the post in divisional director in surgery and is providing real leadership and drive. Spent lots of time, I know, down in theatres understanding what that looks like. And Saganya has been stepping in to help from a medical perspective. And really, Faye and I have to say, have spent a lot of time on this in the last month, trying to make sure we're providing Faye's team and Rabia's team and also my team with the support and impetus to move things forward. Can I guarantee 100% that it's going to go better? better? No, but we are working to actively mitigate all of those risks as we work through the programme. And I think, possibly speaking for Faye here, I think we both feel much more confident now that we've got a plan that will deliver, that we just need to work through. But obviously we'll keep FPC and now CPC informed as we go through that.
I may just briefly, I think that last thing you've said about the commitment of the clinicians is the key thing. I think the stakeholder buy-in, and they're a key stakeholder to these transformation plans, needs to be there. So I don't see it all on you or on Faye to deliver this.
Okay, thank you. Polly, CDC diagnostic stuff, and then Debbie, and then we'll move on, I think, to theatres.
So support exactly what Faye has said, and we'll talk about that a little bit later in terms of there being some immediate short-term opportunities in terms of diagnostic capacity, as well as some kind of medium-term and longer-term. So we can talk through that later. I was also going to just add a reflection on the ophthalmology question, actually. The ophthalmology department at Kettering operates out of the Cave Block, as we delightfully know it, which is an estate that is over 100 years old. It is very tight, it lacks natural light. Patients queue up outside. It's not a nice environment for staff to work in. I have absolutely no doubt that in some way impacts on the ability for us to recruit staff to work in that department. So I think it's key that we sort out the ophthalmology estate, and we do have some plans in place that we're going to start to develop, and I'll talk a little bit more about that a little bit later as well. But I do think the current estate that they're working out of is not ideal and does impact on that recruitment. But hopefully we're going to work over the next year to move ophthalmology out of where they currently are and to provide them with some nice new estates that certainly we're all hopeful, including the ophthalmology clinical leads themselves, that will absolutely impact and improve our recruitment position.
Thank you, Debbie.
Yeah, thank you. Just a couple of points, Chair. So the first one is with regards to mutual aid. I think it's fair to say that we have helped UHL, and while it's not a lot of patients, the help has still been there. So in that regard, Faye and I have been in contact with UHL to see if they can help with our MRI situation immediately. So I'm just waiting for a response on that. And that's the sort of thing that mutual aid we should be able to do rather than transferring money around the NHS system. A second point that I wanted to make was just around sustaining change, and I think there's 2 points here. The first one is quality improvement, quality in its widest sense, making sure that we have got a framework that we're working with and staff know how to make improvement so that it sticks, because I think as an NHS as a whole, and we're no different at Kettering, we're great at making change. We're not as good at making it stick. And what we also need to do is learn from areas where that change has stuck, it has been sustained and made a difference. And if we take falls safety, for example, we know that the changes that we put in have made a massive difference. And that's because the staff on the ground who are implementing the change were involved right from the offset. So it wasn't done to them. And really good communication throughout the programme of work. And also, and probably more importantly, if performance or quality dips for whatever reason, and it will do, it's inevitable that that will happen at times, we pick it up as soon as it dips. We've seen that in complaints, for example, in the last few months. We know when it dips, we pick it up straight away and we start to make change again, and we don't lose sight of that. Thank you.
Okay, thank you very much. Yeah, I think that was good. I think it's important to just understand that everybody understands the assumptions that underpin this and what's changed, and therefore what can be expected now, but make sure we hold people to that expectation. And as you've heard quite a lot today, a lot of it is around recruitment of staff and the pace at which that happens and the efficiency with which that happens. So that's an area that is going to have to be looked at continuously as we go forward. Right, I'm going to move on now to the theatre productivity and the care coordination system. Handing over, continuing the Faye show, but also handing over to Becky to talk us through this. There is a demonstration, I think, of the system towards the end of this, and perhaps whichever of you is starting could introduce your two guests who are at the bottom of my screen at the moment. Thank you.
That will be me. So really pleased to welcome Jo Fernaher from NHS England and Jack Stevenson from the Trust CCS team. So Jo is the Programme Director for the Improving Elective Care Coordination Programme, and Jack is our implementation lead for the Trust Care Coordination System. So we are extremely pleased and fortunate to be part of the NHSE pilot for the Improving Elective Care Coordination Programme, which is providing us with a system which I'll demo, as Alan says, later on in this session, which is really supporting our theatre productivity programme. So I will start with a brief presentation and pause for any thoughts, and then we'll move on to a demonstration of the tool. So we've been talking about it already this morning. It's obviously a really key transformation programme for us within Kettering and across the groups. It's outside of the ICANN programme, it is our best resource transformation programme from my team at the moment. And really aiming to target an 85% theatre productivity. So I've taken this slide from the National Model Hospital team, and this really shows the ambition that we are aiming towards. So there's a national target for this, and you'll see where Kettering and Northampton are on the next slide. We're in kind of high 70% on this chart, but there are only 9 trusts nationally that are achieving the 85% target. And when you put us on this chart, we are in quartile 3. So I think we are in a relatively fortunate position in where we start at. That's not to say there isn't a lot for us to aim and achieve in terms of getting to the best position that we can for our patients. So these are the kind of utilisation of theatres for both Northampton and Kettering. So I've taken this data from the IGR, and you can see on the right there, Kettering Theatres utilisation currently in the high 70s. There are differences between different specialties. Some specialties are absolutely achieving the 85%, and then there are others who are underneath that. So it's not a uniform picture within the specialties that sit underneath it. But really, as I was saying, we've got a programme which is trying to address from the very start of the programme. So have we got the right patients? Are we sure that we've prioritised them appropriately clinically? Have we contacted them, done all of the relative consents, done the right preoperative assessment given their clinical risk? Have we put them into the right theatre session? We're not, for example, putting 2 complex patients into day surgery. Making sure we've got the right staff and with the right skills, and making sure that, you know, a kind of a scrub nurse isn't a scrub nurse isn't a scrub nurse. There are specialties within the skills that people have, with the right equipment on the day. That runs smoothly, and we've talked a bit about making sure that theatres start on time. I know, Chris, you're particularly passionate about that, and that came up when we were talking about this in CPC. Supported by the right systems and the right visibility of data, managed and led by a supportive leadership team who encourages performance, and particularly make sure, I think it was a fair point you made, Debbie, around making sure that when performance dips, we are addressing that. And finally, delivered with a team with the right culture that feels supported and have good morale and enjoy coming to work. So there's a range of different pieces of work which is happening underneath the programme, and I've just highlighted on this where the Trust CCS will support us with some of those different programmes of work. Within Kettering, there's been a real focus on the preoperative assessment process and making sure that we've got a pool of patients who have had a pre-op and we're able to book into theatres. It says on here that the team have lost 2 clinic rooms. I'm pleased to say we've actually managed to locate some space for them, which is extremely fortunate since this paper has been made. So they are now relocating, which will give them the space that they need to be able to assess patients. We've then got the 642 process. So this is the theatre scheduling process. So this is really making sure that we're setting the list up to succeed. So 6 weeks out, are we making sure that we're identifying where we've got people who are on annual leave, and therefore, we can give that session up to another specialty and make sure that we are staffing them appropriately. Between 6 and 4 weeks, you then aim to book all of the patients in. At 2 weeks, you can then lock the list order down, and that allows our SSD department, it allows the equipment to be prepared. It means that we can make sure that where people need HDU beds, etc., we can book those beds in. So that kind of booking and scheduling process. there's been a lot of work on building the competencies of staff within theatres. We've had a number of experienced staff members leave during COVID. So we've then been, Faye's been leading a piece of work with the practice development team to make sure we build those competencies up for some of the more junior members of staff. And then making sure we've got the right systems and the right data. So better visibility of that theatre capacity, of that performance, and in particular that forward look. Until we've got the Trust CCS solution in, to be able to look forward, you have to look individually at each individual theatre session and add up the operation times, which you can do clearly, but would take an awful lot of administrative time to do that. So this will really make it much easier in terms of what that looks like. And then we've talked a bit around making sure we've got the right leadership and culture and engagement from people within the team. So we've been working really closely with the theatres team to make sure we're taking their views into account. Faye and I have been down to visit, and number of the team spend a fair amount of their days down in theatres, understanding what it's really like for staff. So a brief bit about the Improving Elective Care Coordination Programme. So this is an NHSE programme. As I say, we are one of, I think it's 14 pilot trusts, and really provides 4 main areas. So one is an overview of the waiting list. So a complete view of all of the inpatient waiting list that people can go in and look at and use it for waiting list validation. We've then got waiting list cleaning. So we've obviously got a team who support with the cleaning of the waiting list. This will flag some of those issues, make it much more easy to be able to identify where we need to do a bit more investigation around what that patient needs. Then scheduling and booking the theatres. So currently we've got Blue Spear, which supports some of our theatres information, but if you are trying to understand everything, you also need to be logged into health roster and be able to see people's annual leave or availability. You also need to be logged into the preoperative system to be able to see the pre-op status of the patients, and there are some pieces of information that are kept in Excel spreadsheets. So there's a few different places that people are looking at the moment. So this really brings it all into one space, and we can look at that together and have a single place in which to look at everything and make it much more easy to manage the process. We have had some pilot specialties already. So head and neck, general surgery and urology in particular in Kettering have been working with this in the pilot area. We're not rolling it out further because we are addressing some of the issues that the teams have come up with when we've been doing the pilot, but we've clinically reprioritised 3 patients. We've removed 40 patients from the waiting list who no longer required their surgery. We've added additional cases to 17 sessions, so 48 extra patients have been added to those, and those sessions that we've added patients to have had an increase in utilisation. So we're starting to see some of the impact that it will have, and Sarah Hudson, massive thank you to her. She does a lot of our theatres booking. She's really engaged with this, and really appreciate all the feedback and support that she's provided to the programme as we've been rolling this out. So we're aiming to have the full theatre scheduling management system in August. I actually had a workshop with the team yesterday, so we're aiming to have that for the 19th of August. And then we'll have the rollout to all surgical specialties by the end of September, but it means every specialty will have access and will have had access to training by the end of August. We're giving that extra month of support for people for engagement as we go through what that looks like. And just a slight forward look before I go into the demo. We are also looking at including the outpatient waiting list. So this would give us single visibility of the outpatient waiting list alongside the inpatient waiting list, and in particular would be really helpful for the management of the outpatient unappointed follow-up waiting list, which the team have done a phenomenal job at working through, and this will automate some of that work for them. So I will pause there in case there are any questions, Chair, before I move on to a demo of the tool.
Okay. Anything on that at all before we roll straight into the demo? It's clearly a huge piece of work which we commissioned as a major impact on our productivity, our efficiency, and so on. So we might as well have people who know what they're talking about here. Lisa, Chris, and then Trevor.
Thanks, Becky. Really good presentation. Really, what looks like a really valuable tool. Mine was really taking a step back, and Polly will probably giggle at this, is as a system, if we're looking at the waiting list through the elective collaborative, and we're looking to work in partnership with our private providers, how does this, how do we rate looking at the waiting list and decide who does it rather than it's automatically us?
Okay, hold on, let's gather Chris and then Trevor.
Thank you, Alan. So where does the individual operator, the individual surgeon fit into this process so that they understand and know what they're going to be doing in the 642 process? Because certainly when I was practicing, I had more than a little interest in what and who I was operating on.
Okay, thank you. Trevor?
Key to me, or one of the things that seems to be key to this, is the rostering. So you're taking information out of the rostering about who's available, and it's about how robust is that information, and how, if it's not as 100% as we need it to be, how are we going to improve on that?
Okay. Anything else at all, anybody? Nope. Okay. Becky.
So I think in terms of a system waiting list, absolutely the intention is that this is the PTL for the system. We have started by getting in the Kettering and Northampton data, but we have met with our independent sector partners 2 or 3 times to talk about this. It's supported by the System Elective Care Board. In terms of how we make the decisions and how we use that as a system with the elective collaborative, that's work that we need to work through. You know, how will that operate in terms of patient access meetings, etc. Needs designing, and we had a workshop for the elective collaborative last week, and that absolutely is one of the things that we need to work through. We're aiming to have a clinical conference for the elective collaborative in September, and I suspect that will start to explore some of the challenges and possible benefits and opportunities that will bring in that session. But it should provide us with the mechanism with which we can then dock that decision making into. In terms of where the surgeon fits in, so the idea of this is to put the power into the hands of the people who are doing the scheduling and the lists, and actually Chelsea and Westminster, who were the initial pilot for this, very much the scheduling is done by the clinicians. Now here we give less power to our clinicians currently in terms of scheduling than perhaps they do in Chelsea and Westminster, but you would be able to log in if you were a clinician, and you'd be able to see these are my patients for the day, and you'd be able to see your waiting list and your sessions as they were coming up. We are working through with Rob what the 642 process is and what the principles are and what the meeting is at the moment, and doing a refresh of that to make sure that we've got that working, and how the tool will help support do that, and make sure we've got the right people involved from a directorate management perspective, but also the clinicians at the right point in the process. So we'll be designing that with the teams over the coming weeks. And in terms of rostering, it's really good actually, because it links into some of the work which has been done around compassionate rostering and making sure we're rostering far enough in advance. And I know there's been a really great piece of work around increasing the number of rosters that we do 6 weeks in advance. I can't remember where we were, but we're up to the 90%, I think, aren't we, Fiona, in terms of rostering in advance. That's not to say it's perfect, but I think one of the things that this will do, if we're building it into the 642 process, where there are areas that are consistently not rostering far enough in advance, we will be using it actively in a meeting to be able to plan clinical care. So that would be where, linking back to what Debbie was saying around picking up performance, we should be able to go back to those areas and work with them and help understand why that's not happening. At the moment, I suspect some teams feel they put the roster on 6 weeks and it doesn't make any difference if they do it 6 weeks out or 4 weeks out. So this will provide a forum where they know that it's used for something helpful.
Thank you. I suspect it makes a pretty big difference to the staff on that roster, even if it doesn't do anything else. Anyway, anything else on that at all before you slide into the demonstration? No. Okay, Becky, quick demonstration.
Super. So I'll show you a couple of things within here. I'll just start by saying this is not our data. This is a demo set of data, mostly because kept within the tool is patient information, and I obviously don't want to broadcast patient information, but just so that people don't panic when I scroll down slightly and you see that big long bar of 52-week waiters, this is not our waiting list. So don't worry about that. So it does two things really. One, it provides us with an overview as a leadership team on performance, and then secondly, it provides an operational management tool for the teams who are working within this. So we'll be able to see theatres utilisation, and we'll be able to see Kettering and Northampton together for collaborating specialties. For example, Marinal in head and neck, we'll be able to see Kettering and Northampton in the same place and have complete visibility of what that looks like. We've got how many bookings we are doing, the wait listing size, and then we've got visualizations of waiting lists and what that looks like by priority, by how long people have been waiting for. And this screen in particular, in terms of visualizing data, is relatively flexible. And so what we're doing as people are using the tool, we're making amendments to what people would like to see. This chart then shows something which is by specialty. So the blue bars on here are the size of the waiting list for that particular specialty. And then we've got the dots for how much theatre time is allocated and how much theatre time is booked. So this will really help to understand, like I say, this isn't our data, but, on this one, endocrinology has got one of the longer waiting lists. But when you look, there's quite a big gap between the allocated theatre time that they've got and then the number of people that are being able to book in it. So we can really start to use this to say, how can we target those specialties where we are perhaps not making as much use of the theatres as we can, and how can we understand how we can perhaps rebalance some of those theatres to deal with some of the longer waiting lists. This one is extremely colourful, but looks at the different specialties for how the waiting list is made up at different points during the time. So I noticed in the chat there was a question around ENT and the 104-week waiters. So this would provide us with a bit of kind of clearer visibility as to how the waiting list is broken down by specialty over different time periods. So that's the kind of information that we will be able to look at a kind of executive level. But I will just briefly show you some of the other levels. So within the tool, you can see here, this is the patient list. So this is the full set of patients. Again, these are not real patients. And you can see we've got the priority and we've got how long people have been waiting for. We've got information about the procedure. We've got information about how old the patient is, anaesthetic type. POA on here is pre-op assessment. So we're pulling in the pre-operative assessment. What was the last outcome? Was it booked? Have we got so TCI is to come in, so that would be the operation date. Have we got a TCI date? Estimated durations calculated from historical averages, and information about the RTT pathway. So all the information that you would need to know about an individual who is coming in for surgery. and you can click on the patient and you can get some more information about them. So this particular patient, you can see when you click on it, you can see some more information shown in a slightly different way. It also shows you the timeline of events at the bottom. So you can see that little timeline of events. You know, when we'll add in the outpatients as well, we'll be able to see in all the outpatient appointments. So we'll be able to see somebody's entire elective journey throughout their time with us. And you can see here, we can quite easily confirm this person is definitely waiting. Perhaps if I'm a clinician and I've reprioritized this person, I can change the priority, or I can close the encounter, or I can request a theatres booking. Perhaps this person is particularly urgent and requires coming in. So lots of information about the patient for what that looks like. We've also got a view of the theatre sessions. So this time on this list, what you can see are the different theatre sessions, when they are, what theatre is it, what specialty is it, and then information about whether or not that session needs reviewing. So this might say it needs review because somebody is on annual leave. Or this one needs review because it's only moderately booked. So it gives you some information. So this one is low utilised, so that's why it's suggesting that you review that. So that will provide us with a much more targeted way for our booking teams and for our clinicians to be able to look and say, actually, I'm on leave for that one, I best get that session cancelled and offer it up to somebody else in the specialty, or this one gives me low utilisation. And you can see how many minutes are not booked within that session, and what the expected utilisation of that session would be if we are conforming to historical averages for what that looks like. And again, you can click on, let me go back, you can click on this and it will give you some information and detail. Oh, it's just slightly off the bottom of my screen there. I can probably get it on a different screen if I go to one of these. So you can have a look at the upcoming theatre sessions, and it will show you, these are the 7 patients. And all of that information that is in there. We are just looking to get the surgeon's notes included as well, because at the moment they're not quite pulling through, but that's one of the things we'll be pulling through in the next couple of weeks. So then we'll have the surgeon's notes kept within here as well. So if I then wanted to say, actually, I want to have some extra bookings, so there are, you can request patients, but it will also suggest patients. You can see there's a bit at the bottom here around suggestions, and it will automatically suggest some. It hasn't on this one because there's presumably not enough time, but it would suggest some patients from the waiting list for you that would be suitable for that consultant and would fit within the time that we've got. So really helpful to understand what that looks like. And let me just move my screen out of the way because I can't quite do it. So within here, then you could add additional cases. So if I click a tick, you can say, actually, I want to add some cases to this, and it will create an action, and you can assign it to the, whoever it is. So Chris, if you were a surgeon, you could say, I want to add a particular case or a particular patient to my list, or perhaps I want to reorder it. We were talking to Chelsea and Westminster last week, who were saying they use this to make sure they can assign specific equipment requests. So there's a kind of consistent list to go to SSD to make sure that they've got all of the specialist equipment that's needed as well. So it's quite flexible. And in the 642 meetings, you'd be able to then pull all of those different actions together, and it will add them all to, let me find where it is. It will add them all to a request list. So this would then be the action list. which is just loading. And this is the list then that the teams can work through. So some of them might be booking requested, some of them might be specialised equipment, and then this can be something that the team will do. And because there's a relatively live link to our systems, as soon as that's been completed in the system, it will come off this list. So we know that action has been completed because we've had the updated feed from our system, and it will show what that looks like. So I will pause there in case there are any further questions. I am conscious of the time, but hopefully that's a helpful overview.
Thank you very much, Becky. It certainly was a quick run through of what it does. Any comments or thoughts, anybody, on how that works, or any bits of suggestions for further thought? Give you a minute. Nope. Okay. Thank you very much. Good piece of work, Becky. It was good to see. And we do have, of course, a big interest in our theatre efficiency programme, and we recognise it doesn't start and finish at the red line. So widening that into the whole elective journey, the work of the elective collaborative when it starts to fire up, if you like, is all very important. And again, bearing in mind some comments about sometimes we agree these things and don't quite look at them again, I think, you know, some sense of when we might review what's happening in the whole area of theatre productivity through Damien's committee, certainly, but perhaps also at a board slot, so there's a wider understanding of the complexity of the issue. So thank you very much, everybody. Nothing else? No. Right. Thank you very much, everybody. Good piece of work. Moving on, we have the annual report of the Northamptonshire Health Charity. People will remember that KGH joined this charity a little while ago. We haven't had this presentation before, but we can welcome Keith Brooks. He's at the bottom of my screen. And he's going to give us a run through what the charity's done in the last year. We transferred our assets to it in April 2021. So this is effectively the first full year report, which is from April to April. You're very welcome, Keith. Presumably this will be an ongoing event. Over to you, please.
Thank you very much. I apologise to Alan and to Mark. I think they probably have seen most of what I'm going to share, but I have refined it slightly for Kettering in what I've got to say this morning. So I will share my screen, and hopefully I'll be able to share a PowerPoint that will lead you through, which I'm sure you'll see, and does include a video, which I apologise, I think is really rather good. So we'll come on to that a bit later. Thank you for inviting me to talk. Yes, this is the first time I've shared with Kettering. Alan prompted me yesterday and said, Keith, I can't remember the last time you shared with NGH. And I suspect, I struggled to look back, and I think it's 2018, Alan, we did actually do something equivalent. It is interestingly, it is one of the commitments that we make in the Memorandum of Understanding between the charity and the trusts, that I will present the report, not in total detail, but the report of what the charity's done over the year. Obviously, we talk a lot more during the year, so hopefully this will give you a brief flavour and give you hopefully some assurance that we've been looking after KGH's interests as well as the other trusts within the county. So let me just reflect on the year before we, as a start point. We obviously, the formal merger took place on the 1st of April, which was the interesting accounting piece, and thank you to the finance team in Kettering who facilitated that merger well. Other than some interesting conversations regarding, well, I think that's this last year's money, not this year's. We're really, it was really smooth, and really, I would like to place on record my particular appreciation for the KGH finance team. Probably I would mention Sharon as the person that's done the most for us, and her continued connectivity with the charity is really important. So that's an important start point, I think. In terms of grant making for the year, we actually started the year with a relatively empty set of grant requests from KGH. You'd spent a relatively good, significant amount of money the year before, so our grants activity took some time to start up for KGH. That there were things that were in the offering, like buying the equipment, the outdoor gym equipment, using association funding. But other than that, we had quite a low list to start the year. But we've begun to progress. So I remember Janet, when she chaired the first meeting, she said, we haven't got any requests. This isn't good, which was quite amusing. But that's something we need to grow on. I think for me, one of the highlights of the year for the charity as a whole has been funding the Stronger Together programme, which is a programme that NHFT have resourced, but we have used formal NHS Charities Together Stage 2 funding for, but has been offered as psychological type support for all social care and health staff across the county. And I'm really rather proud of that. I have to say, it's probably one of the first projects that's had back to the association that can report, this is what we've done. And I believe it's a really good example of how you can use association funding. Now, I might say that because I have a bit of a biased interest from two sides, but I think that's really important. I think the other thing to say, and I've shared this with Simon, I've shared it with Heidi, I haven't shared it with Debbie. Welcome, Debbie. We've not caught up just recently. We haven't met in the Boots car park just recently either, have we? But there is clearly an impact on the passing donations and the donations towards this year, which is a direct consequence of visitor restrictions, etc. And we do need to be very aware of how we rebuild that process as the hospitals begin to be more open. It's actually most noticeable within NHFT, in that their community units have just basically, their fundraising income just disappeared from the local activities. It's not completely happened in the same way with the acutes. So my first brief reflections on the year. I want to just share with you some the numbers, and this is not this is a non-compliant statement in terms of it doesn't look like what the Charity Commission would require me to report, but it gives you a feel of where money has come in and gone out by each of the trust's own funds. So in terms of income, KGH, you've had clearly a very specifically good year, and Debbie and I shared the day when Crazy Hats handed over the cheque for 390,000. So that 568 does include the donation from Crazy Hats for the extension to the treatment centre, which we haven't physically started spending the money on, but the project is happening. So the 568, no, we didn't do something magical in terms of your fundraising. It was that specific item. Legacies have continued to flow on about the same level as previously. I'm longing to see the large legacy. If I read the legacy press, we're being told there's legacies in the pipeline, but let's wait and see. It's flowing, and it's flowing slowly. We have restarted some fundraising. So the 66 does reflect some specific fundraising, primarily for Twinkling Stars. And I would probably highlight a number of curry evenings that were particularly enjoyable at the Raj as one of the highlights for Keith, because I got an invite to go and I didn't have to do anything at the evening other than say hello to the people in the restaurant, which was, yes, a highlight for me. And it was really good to see Kettering people being really supportive of that appeal. In terms of spend, I'll come on to some of the items where the spending has been. The 12K is the lottery prizes that we give to staff, in that we've always accounted for lottery prizes as a fundraising cost. So I'm showing KGH's lottery prizes as a fundraising cost rather than losing it within grants back to staff. I think it needs to be shown as fundraising. So that's how I've restated that. And I'll come back onto the grants, and support costs are all borne within the central core, which you can see is in the fourth column. So that's a little bit of a feel on financials. As I say, you can see that your previous year, you spent a lot on grants, particularly using the association's grant that you'd received in year. So moving on to some specifics, I've already mentioned the outdoor exercise equipment. That was funded relatively early in the year, and it was good to be able to share some pictures with that back to the association, so we were able to give a final closure report on your use of stage 3 funding. Interestingly, KGH was one of the first trusts to nearly spend all its stage 3 funding. So just to be aware of that, and it was an interesting use of it. I was pleased to see that we funded some chemo pumps and asked for some medical equipment, and there was a little bit of learning around process to make sure we'd got all the approvals right on that, but I'm told that was appreciated and valued. I liked the one about yoga sessions, so I've added that in. You'll notice I've not talked about staff amenities here. I quite deliberately haven't, because that's underlying what we seek to do for all the trusts. But those yoga sessions, I thought that was really good. And it was good that it was a direct donation from Northamptonshire Sport that we could facilitate and make happen. And I've mentioned Tesco's in Corby because that was quite a nice one, and it was good to see it wasn't Kettering, it was actually Corby keen to support the specialist care baby unit. So those opportunities to link commercial operations with us accepting their desire to be charitable is quite an important one. And I think my other specific highlight I would want to include is that we extended the Christmas gift collection to cover all of KGH. It was an interesting challenge in that the logistics for Kettering were that we'd only got a small office, etc. But I believe we managed to do that successfully. So we did achieve my objective, which was to provide presents of gifts for all inpatients on Christmas Day across the county. And I think that in itself was something I feel proud of that the charity achieved. The ongoing underneath that is the staff amenity initiative. So thank you for those as well. So there are some of the specifics. I want to then particularly flag some achievements. I would like to particularly thank those that have served on the subcommittee. Thank you very much. Particularly, I think we should be thanking Mark. Is it Mark's last day today or not quite? So thank you, Mark, for your contribution as part of the... Thank you, Mark, for your contribution to the subcommittee. And I'd also like to record my appreciation for all that Janet did while she was with us on the subcommittee as well. So I'd like to thank you for that. And yes, it's been an interesting learning year and positive. I'd like to also reflect on the fact that we have run a number of new fundraising events, and it's been good to see the Kettering people supporting us and supporting us well across the Kettering site. So particularly those that have been involved with Twinkling Stars. I just hope we can keep the momentum going as you work through the logistics of where that fits into the HIP2 project, etc. So I'm very conscious that that is a challenge that we need to be aware of. And a last achievement is that we've been appointed as the charity partner for the Northamptonshire Chamber of Commerce, which gives me an opportunity to stop sharing my voice, but to let you listen to one of our fundraisers telling you about the charity. And I hope you appreciate the video that I'm about to share. Just to say, we were successful.
Hi, my name's Lorraine and I am one of the community fundraisers here at Northamptonshire Health Charity, and I'd like to share with you why you should consider us to be your next charity partner. With a population of over 700,000, Northamptonshire is served by our 2 hospitals in Kettering and Northampton, plus community hospitals and services located throughout the county. From the very beginning of a new life to end of life, our NHS touches us all at some time in our lives. Around the clock, ready to treat and care for us, and as the charity that supports them, we're proud to fundraise and be there to help. With so many different wards and projects to choose from, as well as our headline appeals, there really is something for everyone, an opportunity for the Chamber and its members to support and fundraise for what really matters to you. From cardiac to cancer, A&E to intensive care, dementia to diabetes, to maternity, mental health, and so much more across our NHS. And what about our unsung heroes, the cogs of our NHS that keep us going? From pharmacy to porters, our domestic and estate teams, our amazing volunteers across both hospitals, we fundraise for them all. We have a shared goal of being there to support our community, and by partnering together we can do this. We can make good things happen and of course have some fun along the way. As we begin to open our doors once again, we will work with you to identify opportunities to spend time with us, to share your skills and volunteer at one of a number of projects we have planned. This is your chance to get involved, from getting stuck into a garden makeover that we're currently fundraising for, to supporting us at future fundraising and profile raising events. Whether it's an adrenaline-filled skydive to running a marathon or joining us on our golf day, we have challenges and events planned, and you are all invited. Have your own idea? We're excited at being shortlisted for Charity Partner, and we want to make sure we get the best out of our partnership with you, which is why we will work with you on your own ideas too. By choosing Northamptonshire Health Charity, you'll be supporting our NHS across the county. Thank you. Hi.
So to some extent, that's good news that we've got the Chamber of Commerce Charity of the Year, but it does actually give me a specific challenge to you all, which is that I do need to have a list of relatively, not always large asks, but cases for need for specific units, wards and departments where a particular member can say, we want to do something and we want to raise some money for something specifically. We don't want to just raise it for the charity. So I do need to ask you, if there are specific cases for need, please think about them and let us know. We tend to end up at subcommittee meetings talking just about we were approving this spend, but sometimes there are opportunities to say, what I need is, I want a list of items that we can also say, can you fundraise for this for us such that we can get it? So be aware that there is that request. That's very much directed at the team, the KGH exec team. The next ask is that when we started a year ago, you gave me a list of fund advisors, and it was a good start, but it is essential that that fund advisor list is kept up to date and is reflective of the way that the trust is now working. So Alison is working with each of the trusts, looking at those current fundraise advisor lists. They act as the charity ambassadors within the hospital. It is really important that you help us to keep those lists up to date. So that's a second ask. Then my third ask is, please encourage your staff to get involved. Now I could give you the challenge that it would be really good to see a team from one of the trusts enter the golf day. But I'm leaving that with you. I'm not saying you've got to, but it would be good. We do get, I have to hasten to add that our auditors do enter the golf day as well. So, but it is not the partner that does our audit that generally leads the team. So think about being involved, encourage staff, specifically things like Spring into Fitness. But when you've got a member of staff that wants to do something specifically, please encourage their fundraising and sometimes maybe even sponsor them. It's really good. I'm not certain that I spotted any faces that are on today's meeting on the video, or whereas yesterday I was able to point at Karen and say, Karen, I can remember seeing her running around Northampton on the day of the half marathon, for instance, in her orange t-shirt. And lastly, my last request is please keep us informed of where you're at with development plans. I need to say that Richard Cook has been really helpful in terms of keeping me updated on what is happening. So thank you for that. But it is really important that we understand where you're going, such that from a charity perspective, we're not completely wrong-footed occasionally. So please do talk with us. And that's a request really to Debbie as much as to anybody. I'm conscious that I talk to Simon as well, but it is helpful to keep us informed and aware, because we do have one or two funds with quite large sums of money in. And it would be totally wrong to be saying, we'll spend it here, if from a group strategy, it would make more sense to do something slightly differently with it. So I leave that with you as my last ask. Hopefully that's given you a relatively quick oversight, and I hope it's encouraged you to believe that you made the right decisions a year ago. I hand over to you to ask me questions.
Thank you very much. Excellent presentation. It's been not a bad first year, although maybe the lack of demand is a bit of a function of how it worked before here, and the fact that we handed out quite a lot of money just before COVID struck to every ward and department. But nevertheless, it's slightly surprising that we have a bigger wish list. Comments and questions, please, for Keith. Fiona.
Thank you, Chair. And it's a comment. Good afternoon, Keith. Lovely to see you. Thank you very much for this presentation. And I've certainly taken note of your requests for sharing with wards and teams, because I know the work that Alison in particular has done at NGH has been really valued. So it would be good to see that replicated on KGH. So thank you again.
Just to say, she's actually talking with some of the team from Kettering today about one or two very specific initiatives while I'm here now. So
thank you very much. Lisa and then Alice.
Good afternoon. Look, thank you for the presentation. It's great to see, and congratulations on all the good work, both fundraising and improvements that you're doing across KGH and the wider group. I suppose I just wanted to build on a bit of Alan's reflection, because I too, I suppose, am amazed that actually for the past 2 years, the bank balance, so to speak, has been growing. We haven't been able to spend what we can fundraise. And given the pressures that we are under, I find that difficult. And I just wanted to understand what more we could do to identify areas to invest the money.
I think there's two different things. There is, when I talk about fund advisors, that one of the things that we've sought to do, particularly in the NGH context, is to encourage there to be a second tier of fund advisors that look at lower item spending requests, such that the process works quicker. And I sense that has been somewhat restricted in KGH previously because of the way some of the processes worked. And I hope we're moving forward on refining that. I hope that answers part of the question. I think the other thing is, from a charity perspective, it is getting the key fund advisors to be thinking, what can we do? Now, I sense the challenge over the last couple of years has been, there's been a lot of other focus. And so that's part of the difficulty. And the big increase in bank balance this year is the 390,000. And I can assure you, we're rather more than, I sense we will end up needing to look for slightly more money than the 390 that has come from Crazy Hats. But we'll see where that one goes.
Okay, thank you, Alice, and then Mark.
Thank you, Keith. That was really, really helpful. I'm just interested. I know a lot of organisations now are moving to not so much pots for donations on the side in places, but much more to electronic forms of giving and contactless giving and so on. And now we are getting more people in footfall in our hospitals. I was just interested if you're looking at ways we can capture that moment when people are with us and they are feeling positively inclined towards us, shall we speak? Let's hope anyway. And how we can give them opportunities to give while the moment is there, and not just give whatever loose change they might have, but to make a reasonable donation with a card, if you like, yes. And to capture that enthusiasm.
To answer you, we already have the technology to give by tapping a machine.
Yep.
So we use that at fundraising events particularly. There have been a number of ventures into having hand terminals within trusts, and a number of trusts have done a number of different initiatives on that. It's not quite as simple as it first sounds, because of particularly networking issues associated with where you put it and the rest of it. So it is doable. The other thing is that if you use one of those wonderful hieroglyphic black dots on a poster, you can actually, using your mobile phone, go direct to donation pages. And quite a lot of our posters do have the ability to, if you scan the poster, you can donate directly from your mobile phone. So yes, we are looking at it. We do tend to try and be relatively innovative, but there is I have to confess, I am an accountant, and therefore I do also ensure that the process works rather than and doesn't cost me too much. So you've got to get it right.
That's helpful. Thank you. I'm glad it's on the agenda.
It is on the
agenda. Thank you very much. And finally, final comment, Mark.
Thank you, Chair, and thanks, Keith, for the presentation. It's been a real privilege to serve on the charity for a number of years, and to move it into the position it's in now with you and the team, where I think it will go from strength to strength. I think on a spend perspective, we do still have a number of fund advisors who like to save up for big items, and that essentially causes us some issues because we have a number of those, and then it accumulates the wealth, as it were, without us actually making some spend. But I think it's also important to generate to how straightforward it is to request some of that money. And Debbie and I have talked about that in sort of our handover and our transition as I hand it over to Debbie, although I'm not so sure. I obviously haven't been able to fulfill the meeting in boots car parks situation, but that's not my issue. So I think there's something there around how we make sure people recognise it's relatively straightforward to do, but also how we get that engagement to the subcommittee, because that's been obviously, given the pressures we've been under, a little bit patchy. There's also the situation with COVID where we had so much money from that charitable donation that we didn't necessarily focus on the ones we have now. But I think it will go from strength to strength with Debbie joining now, and I wish you all the success.
Okay, thank you very much. Thank you, Mark, and thank you for your work on the committee. Thank you, Keith, for the presentation. It's obviously gone down well, and people will respond to your asks. You'll have two new trustees from us in the form of Debbie and another Debbie, actually, two Deborahs, one of whom is our new non-exec who's been appointed with a specific view to filling this role. So, thank you very much for the first annual report. I look forward to getting next year's one with less money in the balance sheet and more things available to see. Thank you very much, Keith. Thank you for joining.
Thank you very much, Alan. Bye.
Bye. Right. that was good stuff. Group board assurance framework. So this has been through all the committees and consolidates and replaces the trust level board assurance frameworks into a single group one. The audit committees endorsed the process and the timescales. All the specific risks and associated scores have been reviewed and endorsed by their responsible committees. Are you happy with it, or are there any questions for Richard? The nods are you happy with it? Yeah, everything else is no questions. Excellent. Thank you very much indeed. Thank you, Richard, and other Richard. Good piece of work. We have a couple of appointments to do. The appointment of Deborah Manger, your new non-exec I mentioned at the start, to the Group People Committee as the KGH NED and convener on that from our side, from the KGH side. You happy with that? I hope so, because it was in the advert. And the second one is to appoint Deborah Needham and Deborah Manger upon commencing office, which is, as I say, the 15th of the month, as the new trustees. Deborah Needham replacing Mark and Deborah Manger replacing Janet Gray. I'm going to have real trouble with two sets of people with the same names. We're going to have a policy in the future. We don't appoint anybody with a name that matches an existing person. I'm getting too old for this clever clock stuff of remembering who I'm talking to. Right, are you all happy with that, those appointments? Good, thank you very much. And any questions from the public? Obviously not. We haven't got any questions from the public, so we don't have anything in that. Any other business? No, jolly good. In that case, we can close. Actually, only joking. We've got Mark Smith's departure. This is in practice his last working day. And we did a little thing yesterday in NGH where he's been for a couple of years, but obviously he's been in KGH for a lot longer. He's been here for, oh gosh, feels like forever, Mark. You're looking around. Eight years, yes. And as you can see on the screen, Faye Gordon had just leapt next door, at least I hope it's next door, or across the corridor at least, with Mark's gift to mark his departure from us. You've been very good for KGH. You've had a lot of influence. Deborah's already said how helpful you've been. The gift is but a small one to take you into the new world with your family. We wish you well as you take up the position with Sussex ICB. And as an aside, we congratulate Paula Kirkpatrick, KGH Director of People 2, stepping up as the acting Group Chief People Officer role. But the primary purpose of this is to say thank you very much, Mark. We wish you and your family well. I know you've wanted to go to the South Coast for a little while. I hope it lives up to its expectations. Hope you enjoy the gift you got. For those of you that don't know what it is a gold family membership of the London Zoological Society, which was Mark's ask. I'm sure there's all sorts of hidden logic behind what that is about. But anyway, well done, Mark. Thank you very much for the 8 years at KGH and the bit in the group. Good luck in the future. Thank you.
Thank you. Thanks very much. And I need that Zoo pass because I've got a lot of children to foster around. So, give them good education. Thank you all. It's really kind.
And one day you'll stop having children. I'm sure that will be helpful as well to the bank balance. Right. Thank you very much, everybody. 1:15 for the private meeting, different link. Look forward to joining us then. It was a good public meeting. Thank you very much indeed. Bye.